طيب, Assalamu alaikum everyone. My name is Rafah Chahine. I'm a fourth year medical student. I hope you're all having an amazing day so far, inshallah, and a blessed Friday. Today I'm going to be teaching you everything you need to know about the anatomy of the thorax. And this includes the anatomy lectures by Dr. Lena, anatomy lecture 1, 8, and 9. These objectives are pretty unremarkable. So if you want any more detailed objectives, you can go ahead and check the objectives that Dr. Alina has in her lecture. Now, I think we have a pretty decent amount of people here. I think we have like four, which is very awesome. Um, and this means that this is going to be a pretty interactive session. Try to answer questions that I ask, even if they are right or even if they are wrong. I honestly do not care. All I want to see is you guys trying to come up with the answer. And because this is going to be interactive, feel free to raise your hand on Zoom and write down any questions you've got in the chat. I have the chat open here, so inshallah I'll get to them and answer them. One last thing about interaction is if I ask you, okay, is this clear? Can we move on? Please just say yes. It helps a lot with my flow and it makes sure that you guys are getting the point. But yeah, let's get started. So, firstly, what is the thorax? When I say thorax, I'm talking about the superior part of the trunk. What is the trunk? When I tell you, yo, what is the trunk? You will tell me, hey, it's the part of your body that is from the waist up towards or up until the neck, all right? So the thorax is a superior part of the trunk, which starts at the base of the neck, which starts at the base of the neck right here and ends at the upper abdomen. Now, we can divide the thorax into two. We have the thoracic cage and the thoracic cavity. So we're going to start with the thoracic cage and get to the cavity later on. So from the name, what in our body looks like a cage? The ribs, okay? So when I tell you the cage, I'm talking about all these bony structures, okay? We have the ribs, we have this bone in the middle right here called the sternum. We have these, which are the clavicles, aka your collarbones. We have this bone in the back. This is your shoulder blade or your scapula. And behind all that, we have the vertebrae keeping it all together, aka your backbone. What is the function of the thoracic cage? It is to protect vital organs, like the ones that are inside, like the lungs and the heart. And also, the function of the thoracic cage, like any other bone, is to provide attachment points for muscles and tendons. Okay. Superior to it, what do we have? We have the rest of the neck, and inferior to it, we have the abdomen, which is separated from the thoracic cage or the cavity by the diaphragm. And we're going to see all that. Okay. Now, just like any other part of our body, we have surface anatomy to the thorax, okay? So firstly, let's start off with this mid-sternal line. I told you in the center right here, we have this bone called the sternum. This, if I draw a line down the middle of it, we have the mid-sternal line. And then right next to it, we have the parasternal lines. Anything that says para means next to, okay? This applies to absolutely everything, okay? And then here we have the midclavicular line, which is the line that goes right down your clavicle or your collarbone. Like, what is the importance of this surface anatomy? If I tell you, I want you to feel the apex of the heart. The apex of the heart is the absolute tip of the heart, right? The what's it called? You know, the heart is like an upside down pyramid. The tip of it is called the apex, right? I want you to feel the apex of the heart from the outside. How are you going to do that? You're going to go down the midclavicular line to the fifth intercostal space. What is an intercostal space? Anything that says coastal relates to the ribs, okay? In between the ribs, you've got a space. That is the intercostal space. We go down to the fifth one. That's where you're going to find the apex of the heart. Okay, now we're going to move on to the anterolateral view. Anteriorly, but now we're looking at the side, okay? What do we have on the side? We can see the armpit. In medicine, this is called the axilla, okay? Or the axillary fossa. I draw a line down the middle of it. We're going to call that the mid-axillary line. I draw a line in front of it. We're going to call that the anterior axillary line, which starts or begins at the anterior axillary fold. This anterior axillary fold, the line of it is made by this muscle right here, okay? This muscle is a muscle you train at the gym, your pecs, your pectoralis major, okay? Behind this mid-axillary line, we have the posterior axillary line. This is a line that goes down the posterior axillary posterior axillary fold, which is marked by two muscles that you are not going to take in detail in this block. You are going to take them later on in MSK, and those are your latissimus dorsi and your teres major. Well, did you take them? Well, I don't know. You probably took them, I think. Latissimus dorsi and teres major, they make the posterior axillary fold, and that's where your posterior axillary line is going to go down into, all right? Little fun fact just to throw it in there. Latissimus dorsi is also known as the swimmer's muscle because it's the muscle that you use when you're swimming, predominantly. Okay. Now, posterior view, we have the vertebrae. We do not have the sternum anymore, right? Now we're looking at the back. In the back, we have the mid-vertebral line, also known as the posterior median line. It's posterior because it's on the posterior, median because it's down the middle, and line because it's a line. Okay. Then next to it, we have the paravertebral lines. Again, anything para means next to. And along the lateral border of the vertebrae, we're going to see that later on. And then if you remember the scapula or the shoulder blade, this one, if I were to run a line down the inferior border of it or the inferior angle, we would call that the scapular line. Like, now let's move on to the borders of the thoracic cage. This is the thoracic cage. Anteriorly, I have the sternum and I have the costal cartilage. Costal again means ribs. How do the ribs attach to the anterior part of your thoracic cage? Through cartilage. And so the sternum and these costal cartilages are going to make up the anterior border, aka the border that is in the front. Okay. Laterally or to the sides, we're going to have the ribs and their intercostal spaces. Again, intercostal spaces is this space in between each one. Posteriorly, we have the backbone, so the thoracic vertebrae. And then superiorly, we have the suprapleural membrane, which we're going to see. And inferiorly, we have this diaphragm. Like, what is the suprapleural membrane? So you've taken these lectures before. You know that the pleura is the membrane that covers the lungs. We have a membrane on top of that. That's why it's called suprapleural. And that membrane covers the apex of the heart, and it can also extend up to the root of the neck. That's basically it, okay? But now for the diaphragm, this diaphragm is also known as the respiratory diaphragm. It is one of the most, if not the most important muscle in your body. Very debatable, by the way, many people do not agree. It is the muscle that is basically keeping you breathing. Without the diaphragm, say bye-bye to breathing, say bye-bye to respiration, right? So it is a dome-shaped muscle that covers the inferior side of the thoracic cage, and it separates the thoracic cavity from the abdominal cavity. Okay. Now, like, see this part over here? This superior part, it's facing the neck, right? And this inferior part, it's facing the abdomen and it is covered by the diaphragm plane. This superior part over here, we're going to call the thoracic inlet, okay? Or more specifically, to be more nitpicky, we're going to call it the superior thoracic aperture. What do we know about, I hate this word, aperture? We know aperture from cameras. At least I do. At least that's where I knew it from. Imagine this is a camera, okay? If I zoom in, zoom out, the size of the lens inside, it changes shape. How open the lens is the aperture, okay? So when I tell you superior on the top, thoracic aperture, it means it's a superior opening of the thoracic cavity. طيب. Otherwise known as the thoracic inlet. They call it the inlet, okay? The anatomists, they call it the inlet because things go inside it, okay? Anteriorly, what do we have? We have the manubrium of the sternum. Remember the bone right in the center? That's the sternum. The sternum can be divided into three parts, and we're going to go into those later. The first part is the manubrium, and that's what makes up the anterior boundary or border of the thoracic inlet. Medially, we have, laterally, we have the medial border of the first rib. This is the first rib, the medial border or the border that faces the middle of the body, okay? And posteriorly, what do we have? We have the first thoracic vertebrae or T1. And all of this is color-coded for ease of understanding. Fine. Now we're going to move on to the thoracic outlet or the inferior thoracic aperture. This is the inferior opening of the thoracic cavity. And what does it communicate with? What's under here? The abdomen. And it is closed off by the respiratory diaphragm. Its boundaries, let's start anteriorly. Anteriorly, we have the third part of the sternum, also known as the xiphoid process. Here, they're just going to say xiphisternal joint because they're taking into account this entire connection, okay? Laterally, we have the costal margins. Margin is the end of a certain portion of something, and so the end of the ribs is going to be called the costal margin. Posteriorly, we have the last thoracic vertebrae, or T12, okay? What does this allow for? Passage of the esophagus, the IVC, the aorta, and a bunch of other nerves and very important structures, okay? طيب. Now, before I move on, I've been saying thoracic and the thoracic outlet, and right now, okay, if I tell you to leave this, don't leave the Zoom meeting, but if you exit the tab and you go and you search thoracic outlet, you're not going to get a picture of this. What you're going to get is a picture of this. This is considered the thoracic outlet in the clinics, okay? Why? Because clinicians and anatomists cannot agree for the love of everyone, okay? Anatomists, they call this the inlet because the esophagus and the trachea let food and air inside. So they called it, oh, okay, this makes sense, inlet, okay? Clinicians, on the other hand, they're looking at more, I don't want to say important because I'm discriminating, but yani more vital structures like the subclavian artery and the vein. Okay, this subclavian artery and the vein, they are branches of the aorta and the superior vena cava, right? These branches are very important and they do not go into the thorax, no, they leave the thorax, the thoracic cavity, right? So that's why the clinicians called it the outlets. Now, another structure that leaves the thorax is this T1 nerve, okay? T1 nerve is this one, and it comes out of the spinal cord at the level of the T1 vertebrae. It goes out of the spinal cord and it supplies this thing called the brachial plexus. You're going to take this later on in MSK, but for now, the brachial plexus, it's a collection of nerves that supplies your upper limbs, okay? And this is just a picture. Shows you red for anatomists and green for clinicians. Red, again, anatomists, they say food and air go in, so inlet. But then clinicians say, oh, subclavian artery and vein and T1 nerve out, so outlet. I highly doubt they're going to ask you about this because it's very nitpicky and very nifty, so it's honestly useless. Um, but in case they do, I hope you understand it. Right. So clinicians call it thoracic outlet. So obviously we're going to have a disease after it. Okay, that's going to be called the thoracic outlet syndrome. I told you, the thoracic outlet, it's called the outlet because the subclavian artery and the vein, they leave, and the T1 nerve, they leave. Like, imagine I compress those structures. I compress the nerve, I compress the subclavian artery and the vein. What am I gonna call this disease? Thoracic outlet syndrome, okay? This is due to the compression of these neurovascular structures, and this compression can result in pain, numbness, and tingling of the upper limbs and possibly head and neck, okay? Um, the pain, the kind of pain that these patients get is ischemic pain because they lack blood supply to the upper limb, right? Okay. How can this compression occur? It can occur in one or two ways. Number one, there could be a mass, right? There could be a tumor, there could be a mass somewhere around that area that is compressing these structures, or it could be this thing called the cervical rib, okay? And we're going to get to what the cervical rib is, and I'm going to remind you of thoracic outlet syndrome when we do. Now, this tumor that I'm talking about is called a Pancoast tumor. All you need to know, I think, for this lecture at least, is that a Pancoast tumor is a tumor of the apex of the lung, okay? So it's right here, and as you can see, if I were to zoom in, this is your subclavian artery, this is your subclavian vein, this is T1 that goes and joins into your brachial plexus. This is the tumor. It might compress on these things, and it will cause this thoracic outlet syndrome, pain, numbness, and tingling, okay? Awesome. Now we're going to move on to the actual bones, starting off with the sternum. The sternum can be divided into three main parts. We have the manubrium, the body, and the xiphoid process. Okay, starting off with the manubrium. A few important things that I want you to note about the manubrium is number one, the jugular notch. The jugular notch, you can actually feel it. It's right here. If I were to take a deep breath in and hold, and I'm currently touching my jugular notch, okay? And then another thing that I want you to note is the articulating site of the clavicle. Remember your collarbone? If I were to touch the jugular notch right now and I go to the right or to the left, the first thing that I'm going to feel is my collarbone, right? Because that's literally where it attaches, as you can see right here. There's also a full attachment site for rib number one. And now, okay, here's what I want you to keep in mind, okay? We have a demifacet for rib number two. Now, you're probably wondering, what in the world is a demifacet? Like, a facet is a point where two bones meet, okay? In simplest terms. When I tell you there is a demifacet, it means that there is half of a point where the bone should meet. So if I were to get rid of the rest of the sternum, rib number two would only attach half of itself to the manubrium of the sternum, okay? The rest of the demifacet or the rest of the attachment for rib number two is going to be on the body of the sternum. That's why we have articular demifacets. That's why they put them together and it's for rib number two, okay? Now, moving on to the body. In the body, you have all these ridges, and these ridges, they signify where you have the articulating points of the ribs. What ribs are articulating on the body of the sternum? Technically, we have half of rib number two, because it has a demifacet for it. We have 3, 4, 5, 6, and 7, okay? What about, it says right here, it's ribs 3 to 9. What happened to 8 and 9? We're gonna see later, okay? Under the body of the sternum, we have the xiphoid process. This xiphoid process is not a bone, it's a hyaline cartilage, okay? It's a thin plate of hyaline cartilage that does become bone in your adult life, okay? Is the sternum clear? Oh, hell no. It's my Wi-Fi. 1 second. Oh, okay, not my Wi-Fi. All right, my bad, my bad, my bad. So I can proceed. Do I continue? Okay, awesome, awesome. It's chill, no worries. طيب, let's continue. Is the sternum clear? Awesome. Wait, why is my... Okay. So we're done with the sternum. Now let's move, okay, to... Okay, yeah. So now, another important part of the sternum is the sternal angle of Louis, okay? So we have two meeting points at the sternum, right? The manubrium meets the body of the sternum, and we're going to call this the manubriosternal joint. And then the body of the sternum meets the xiphoid process, and we're going to call this the xiphisternal joint, okay? Remember how I told you, the anterior border of the inferior, what's it called, of the inferior portion of the thoracic cavity, the anterior border is the xiphisternal joint. That's the xiphisternal joint, okay? طيب. Now for the sternal angle of Louis. The sternal angle of Louis, you can feel if you go from your jugular notch, continue downwards, you're going to feel this kind of bump. That's your sternal angle of Louis. Why is this very important? Because it helps us count ribs, okay? Uh, Rib number 7 has demifacets or just a facet. Rib number 7 has demifacets, okay? So if you look closely, this is the body of the sternum, and this is the xiphoid process. There's a demifacet here and a demifacet here. So rib number 7 attaches to both the body and the xiphoid process. Awesome. Okay, let's go back. So the sternal angle of Louis, if you take your jugular notch, okay, slide your finger a little bit down, you're going to feel this bump. That's the sternal angle of Louis. Like, move to the right of it. What do you find? The second rib. Why? Because if we look at the sternal angle of Louis, what's right next to it? The articulating demifacets for rib number 2. So you're going to feel the second rib. Like, if I tell you, okay, I want you to feel the apex of the heart. Can someone tell me where the apex of the heart is at? Where can I feel it on the body? Fifth. Do you want to complete that sentence? Fifth intercostal space midclavicular. Yes, awesome, awesome. Y'all cooked. Okay. So yes, it is the fifth intercostal space. Bismillah, we have 17 people. Whoa, that's crazy. Fifth intercostal space, midclavicular line. Okay. So how do we get to this fifth intercostal space? We go down jugular notch, feel the sternal angle of Louis, go to my right or to my left, wherever. Obviously, we're going to go to the left if we want the apex of the heart. We're going to count, go under it. That's the second intercostal space. Under it, that's the third rib. Under that, the third intercostal space. Under that, etc., etc., until you reach the fifth intercostal space, midclavicular line, you'll get the apex of the heart. طيب. So, number 1, it helps us count the ribs, okay? Number 2, the sternal angle of Louis is opposite to the level of the thoracic vertebrae 4 and 5, okay? This is very important, and we're going to see why it is important later on. What is important about T4 and T5 for now, though, is that marks where the trachea bifurcates into the bronchi, right? What if they say which ribs are attached at the manubrium? Do we say second or half of it? No, you say, okay, so which ribs are attached to the manubrium? You're going to say first and second, okay? Because technically the second still attaches to it, you know? And if they ask you, okay, what other bony structure attaches to the manubrium? You're also going to add the clavicle because it has the articulating site here, okay? Awesome. Um, Yeah, so what does the sternal angle of Louis mark for now? It marks the bifurcation of the trachea and the end of the arch of the aorta. So this dotted line, it shows us the level of the sternal angle of Louis. Above it, okay, if we zoom closely, this is the arch of the aorta, and it starts and it ends. And this is the trachea, and you can't really see it bifurcate, but it bifurcates at this level, and this is T4 and T5. Like, what other significance does the sternal angle of Louis help me with? It separates my mediastinum, which is another lecture that we're going to get to in a bit. It separates the mediastinum into the superior mediastinum and the inferior mediastinum. So if they ask you, okay, what separates or at what level is the superior mediastinum, what does the superior mediastinum end? You're going to say at the level of the sternal angle of Louis at T4, T5. Okay? طيب. Now we're going to move on to the clinical significance of the sternum. Firstly, the sternum is one of the main points or parts of our body where we take a bone marrow biopsy. Why? It's right here, easy access. It's really broad, it's really wide, it's very hard to miss. And also, it just contains hematopoietic cells throughout your entire life. And so it's very easy to take a bone marrow biopsy from there. The other clinical significance is for median sternotomy, which is an incision made in surgery. They'll draw a line, the mid-sternal line, right? They'll make an incision, and then they get easy access to thoracic organs like the lungs and the heart. Okay, we're moving on. Now we're going to start off with the ribs. So we have 12 ribs on each side. Okay, I accidentally skipped the slide, sorry. We have 12 ribs on each side, making it 24 in total, okay? Each rib is going to correspond to and attach to a thoracic vertebrae from the back, okay? So if we look closely, this is rib number one, and it attaches to a vertebrae in the back. Rib number two, the same thing, okay? Each rib has an intercostal space under it. So if I tell you, okay, where's the intercostal space for rib number five, you're going to count like one, two, three, four, hide the rib number five. Under it is fifth intercostal space, okay? طيب. Now we have classifications of ribs. We have true, false, and floating. Okay, let's make this easy. True ribs are ribs 1, 2, 3, 4, 5, 6, and 7. Why are they true? Because they have their own costal cartilages to attach to the sternum anteriorly. Now, is this clear so far? Do we get true ribs? Awesome. Now we're going to move on to the false ribs. The false ribs are those that do not have their own costal cartilage, okay? So this was 7, right? Let's count under it. 8, 9, and 10. Not only do they have their own costal cartilage, sure, but they do not use it to attach to the sternum. Their costal cartilages, not only do they fuse together, but they also fuse with the seventh costal cartilage, making them false. So far, true ribs 1 to 7 because they have their own costal cartilage attaches to the sternum. False ribs 8 to 10. They have costal cartilages that fuse together and do not attach on their own. Now, for the last category or classification of ribs for now is the floating ribs, yani 11 and 12 in the back. They have nothing to do in the front, okay? They do not attach anteriorly. They end at the abdominal muscles in the back, okay? Okay, now we're gonna move on to the second classification of ribs, and then after that, I'm gonna check up on you guys again and see if you still get it. Like, now we have typical, atypical, typical and atypical ribs. Okay, you're gonna notice there's gonna be a trend. Everything in the thorax is typical and atypical at the same time. Play. Typical ribs, they follow a very, very default design. Okay, what's that design? They have a head, which is this. Okay, and the head has to have two articulating points. Do we see one and we see two? Okay, so typical ribs have heads that have two articulating points. Keep that in mind. Like typical ribs also have head necks. They have tubercles, which attach to the transverse processes of the vertebrae, which we're going to see later on. They have bodies, which form the angle of the ribs and provide us with this costal groove right here, which is a thinner segment of the rib. And that is where the arteries and the veins, they're all going to rest and snuggle up against each other to stay safe. And that is the typical rib design. And those are ribs 3 till 9. Are we clear? Yep. Yes. Okay. Awesome. Now we're going to move on to atypical ribs. So I told you typical were 3 to 9. So atypical ribs are going to be 1, 2, 10, 11, and 12. It kind of sounds like a song, okay? For 1, 2, 10, 11, and 12, yani, there's a rhythm to it, you feel me? That's how I remembered it. I fought demons to try and find pictures of rib number 2, 10, 11, and 12. I failed miserably. So I present to you a picture of rib number 1. And I'll try my best to explain the rest. So rib number 1, why is it atypical? 11 and 12 are floating ribs, yes. Okay, so why is rib number 1 atypical? It is atypical because number 1, it is the shortest, the flattest, the broadest, and the most curved, okay? Super curved, super flat, super short. Awesome. It has a head, but this head has only one articulating facet, okay? One articulating facet. It has a neck, it has a tubercle, awesome. Everything so far has been a little bit typical, a little bit atypical, right? The only atypical things we've mentioned is its size and its shape, and the fact that it only has one articulating facet on its head. طيب. Now, what actually makes it atypical? It has the scalene tubercle. Tubercle is an impression on the bone. It is a protruding impression on bones, right? You're going to see it a lot when you take other bones. A scalene tubercle, though, is where the scalene muscle attaches. Scalene is one of the muscles that you'll find around your neck area, and it's going to attach to the first rib, and that is where it attaches. Then it has two different grooves. These grooves are the subgrooves for the subclavian artery and the vein. Let me show you a clearer picture. Okay, this is rib number one. Do you see the subclavian artery and the vein? They literally sit on it, but they have their own grooves for on that rib. Okay. Is rib number one clear? Awesome. Yeah. Okay. Rib number two. Now, rib number two, I'm going to try and explain as best as possible. Imagine it kind of looks like rib number one, but it has two facets on its head, and it is very flat. The fact that it's flat is the only thing that makes it atypical. The deeper groove is for the artery. Yes. Wait, what? Which one is the deeper groove to you? This one is the deeper groove to me. Let's go back. Okay. Yeah. So the arteries in the back, because the veins are always in the front, because they have to protect the arteries, they're kind of more vital. And so the groove that's in the back is going to be for the subclavian artery. The groove in the front is for the subclavian vein. All right, thanks. So if the scalene tubercle is there, then yes, it's immediately rib number one. No other rib has the scalene tubercle, okay? Okay, I'm gonna assume yeah. Like, so rib number two, we said that it has two facets on its head, which is pretty normal, but then again, it is flat, so that's what makes it atypical. طيب. Now we move on to rib number 10. Rib number 10 has only one articulating facet on its head. Only one, okay? Rib number 11 and 12 also have only one articulating facet on their head, but they also do not have a neck or a tubercle, okay? So are the atypical ribs clear? Can you repeat which groove is for which? Okay. Look at this rib, okay? This is the anterior portion. This is the one that's going to attach to the sternum. And this is posterior attaching to the vertebrae. This groove right here, this one, where I have my cursor, that's for the subclavian artery. This one is for the subclavian vein. There's a general rule in the human body where veins are always in front of arteries. Okay? So if they give you this picture in the OSCE or in the whatever MCQ, and they ask you which one is which I highly doubt they will, by the way, highly doubt. The one in the back is for the artery, the one in the front is for the vein. Are we good? Awesome. Are atypical ribs clear though? Awesome. Now we move on to the cervical rib. Remember how I told you isn't two facets normal? You're talking about rib number two. Two facets is normal, but again, the shape of the rib itself is weird. It's flat. It's flatter. You feel me? Yeah. Now we move on to the cervical rib. I mentioned the cervical rib when I was talking about thoracic outlet syndrome. But what is cervical rib? So you have your backbone, right? Your backbone or your vertebral column can be divided into different parts. Do you guys know those parts? I'm gonna take that as a no. Yes, you know those parts. Okay. Can you name the first part of the vertebral column? Awesome. Yes. So you start off with the cervical, then you go down to the thoracic, then the lumbar, then sacral, then coccyx. Okay. CTL. Exactly. So we're starting off with the cervical. In the cervical portion of your vertebral column, you have seven vertebrae, one till seven. Okay. Your seventh cervical vertebrae, it has a transverse process just like every other one. But the thing is that there could be a mesenchymal or a cartilaginous elongation coming from that transverse process. And that will turn around and it will curve around your neck. And that's what's going to make this cervical rib. That's why it's not a real bone. It's not an actual bone. Plus, only 0.5% of the population have the cervical rib. Good luck finding someone with it. You feel me? طيب, what can this cause? Can someone remind me? TOS, thoracic outlet syndrome. Thoracic outlet syndrome is compression of which neurovascular structures? Subclavian T1, subclavian and T1, T1 nerve, exactly. Don't write T1 in the exam. Make sure you write T1 nerve. T1 is, you feel me? T1 is your vertebrae. Uh, what do you mean by C8? There's no C8. Okay, we're gonna move on. I'll read your answer whenever you write it down. Okay, the brachial plexus of TOS. Okay, yeah, sure, yeah. Okay, you can say C8, but يعني for now, just keep it T1 for the sake of CVP. You feel me? طيب. Now we're moving on to rib fractures. Can someone tell me where are the rib fractures here, or are the ribs even fractured in this picture? Yeah, okay. That's all I wanted. That's all I wanted. طيب. The one thing that I want you to know in this picture is the location of these fractures. They are fractured at the angle of the rib, okay? The most common area for ribs to get fractured is at the angle of the rib, okay? Keep that in mind. طيب, in this picture, are the ribs fractured? Looks like it. Okay. No, 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 knee. Okay. So the ribs are fractured here. Okay. There's one singular rib fracture that we can see, and it's right here. But on top of that, the clavicle is completely gone. In this patient, I honestly, I'm not super into clinical stuff like that, but I can think or I can imagine that the patient's skin is being pierced by this fractured clavicle. Okay, just a little thing I added in there. So yeah, the rib is fractured here. Fine. Now I have a question for you. What is the most common site of rib fractures? Quick angle. Okay, then do these patients feel any pain? Yes, yes. Yes, طيب. Do you guys know where that pain could be felt? Or where is it going to originate from? Upper limbs? Okay. Chest wall? Okay. Good guesses, good guesses. And is there something that I'm concerned about when it comes to rib fractures? Lungs. Okay. Lung puncture. Exactly. طيب, mashallah alaikum, you guys. Y'all are I hope y'all didn't hear that motorcycle. Y'all are eating this up. Okay, طيب. So the most common site, angle of the rib. Now, where's the pain? On the nerve that is running in the coastal groove. Remember, I told you that the body of the rib can form this thing called the coastal groove where the artery and the vein are going to sit. There's also going to be a nerve there, and that's where the pain is going to originate from, okay? Obviously, not the only area you're going to feel pain in, but that's where it's going to originate from. And as you guys rightfully mentioned, we are scared of the sharp edges of the fractured rib to puncture the lung, all right? Like, now we're gonna move on to typical vertebrae because I told you everything in the thorax is typical and atypical. Now, this is gonna look like a lot, but we're gonna go through it step by step, okay? So, typical vertebrae are T2 to T9, okay? Starting off with uh, whoa, major glitch. Sorry. So typical ribs are vertebrae. Typical vertebrae are T2 to T9. Okay. They all also follow a default design. Starting off with number one, they all have a spinous process and they all have a transverse process. Okay. Spinous process is the thing that you can literally feel on your back sometimes. That is the spinous process. The transverse process, I want you to recall. Let me keep this for later. Play. So spinous and transverse, typical vertebrae. Second thing is vertebral foramen. This is where your spinal cord is going to go in, okay? Then you also have a superior and an inferior articular process. These articular processes are not for your ribs, okay? They are for the vertebrae above and below. That's why your vertebral column can flex and bend, okay? And the last thing making them typical are the costal facets, okay? Now, let's put our brains together. In typical vertebrae, there is one superior costal demifacet and an inferior costal demifacet. Notice how I said demifacet? This is important, okay? They are not complete facets, okay? And you have a third costal facet, which is the transverse costal facet. Remember the tubercle? Remember this tubercle and how I told you this is going to attach to the transverse processes of the vertebrae? The costal facet on the transverse vertebrae is where the tubercle is going to attach, right here, okay? Are typical vertebrae clear? Awesome. Now we're going to move on to atypical vertebrae. For atypical vertebrae, we're only, so it was T2 to T9 for typical. Atypical is T1, T10 to 12, okay? So T1, why is it atypical? First of all, there is one complete costal facet for the full attachment of rib number one. I want us to put our brains together and recall, was rib number one atypical or typical? Atypical. Okay, so we know that it's atypical because of its shape and size, but can someone tell me another thing that makes it atypical that relates to this facet on T1? Scalene tubercle, one facet, exactly. So the scalene tubercle makes it atypical, yes, but the one that I'm talking about right now, specifically for this T1 vertebrae, is the singular facet. So because it only has one singular articulating facet, T1 has one complete costal facet on it, okay? But it also has one more demi-facet for rib number 2, okay? طيب, for T10 and T12, again, fought demons and failed miserably to try and find pictures for each one separately. So I just found for T10, and it's in Spanish, but I think we can put our brains together and translate. But T11 and 12 kind of also look like this, so we're good. What makes them atypical? They only have one complete facet, okay? Can you guys remind me, ribs number 10, 11, and 12, were they typical or atypical? Float, yes, float, atypical, exactly. They were also atypical. Why? Because they only had one articulating facet, right? They had one articulating facet because their vertebrae only have one articulating facet. So T10 can only hold T10. T11 can only hold T11, and same for T12. Are we good? Awesome stuff. But this is showing you how typical ribs articulate. Typical ribs and vertebrae articulate. So we got T6, T7, and rib number 7. They're all typical. But let's quick review, okay? T6, this is the vertebrae, okay? This is the superior costal demifacet. This is inferior costal demifacet covered by this rib. We have a transverse costal facet as well. This is the superior articulating facet, and this is the inferior articulating facet, as you can see, articulating with the vertebrae under it. This is horn right here. These two horns are the transverse processes, and this is the spinous process. طيب. Now let's review typical rib number 7. This is the body. You can't see it, but there's going to be a coastal, oops, there's going to be a coastal groove right here. This is the tubercle articulating with the transverse costal facet of T7, because this is rib number 7. And it has a neck and the head with two articulating facets. Now, notice. Remember how I told you there's two articulating facets? Now, the one on the top, okay, on the head of rib number 7 is not going to articulate with T7. It's going to articulate with the inferior costal demifacet on T6. And the second articulating facet on rib number 7, the one at the bottom, that is going to articulate with the superior demifacet of T7. Is this attachment clear? Is this attachment clear? Awesome stuff. So, are we good to move on? Like, we're going to start off with the vasculature of the throat, so it articulates with the one above it. Yes, that's why we have demifacets in typical vertebrae. Because remember how typical ribs, they have a head that have two articulating facets. The one above is going to articulate with the vertebrae above it, and the one below is going to articulate with its own vertebrae. Do you get me? Folks, okay, let's go. So now we're going to start off with the vasculature of the thoracic cage. We're going to start off with arteries and nerves and veins and da 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 da. Okay? طيب. What did I tell you sits in the costal groove? Vein. Yes, vein, artery, and nerve. Awesome. Yes, so we're going to start off with the arteries. Okay? Now, I want you to picture we have a rib cage. Do you think arteries are gonna be fully energized and not lazy enough to go throughout the entirety of this rib? Me personally, would immediately say no. So we're gonna have a posterior intercostal artery and an anterior one. Now we're gonna start off with the posterior, okay? So this is half of a complete picture. We're gonna see the complete thing later. Now, we're looking at the posterior intercostal arteries. I want you to split them up into 3 different parts, okay? Part number 1 is that we have an artery that only supplies the intercostal spaces of 1 and 2, okay? So we have one artery supplies first 2 intercostal spaces, and that's it. Then we have another artery or another bunch of arteries that supplies the intercostal spaces from 3 till 11. And lastly, the intercostal space of 12, aka literally the abdominal cavity under the 12th rib, that's going to be supplied by this artery called the subcostal artery. The ones that are highlighted are the ones that we're going to mention in this slide specifically, okay? طيب. Let's start off with the intercostal spaces of 1 and 2. We said that those are going to be supplied by one artery. Where does this artery come from? You guys know on the right and on the left, from the aorta, we can get subclavian arteries, okay? Excuse me. There's a branch of the subclavian artery. It's going to be called the costocervical trunk, okay? This costocervical trunk, it's going to give me an artery called this posterior intercostal artery, which is what's going to supply the intercostal spaces of 1 and 2. Are we clear so far? It's pretty simple so far. Awesome. Okay. Now we're going to move on to intercostal spaces 3 till 11. Those, very simply, they're all going to come from the descending thoracic aorta, as you can see right here. Okay. Now let's move on to the subcostal artery. This is the complete picture. I broke it up to not overwhelm, but this side is the one that shows the subcostal artery, okay? So as you can see, from the descending thoracic aorta, we get this branch right here. That's the subcostal artery supplying the space under the 12th rib. Are we good with the posterior intercostal arteries? Tamam. Yay. Okay. Now we're going to move on to the anterior intercostal arteries. Like anterior intercostal arteries, I want you to split them into two. Okay, we have an artery that supplies the first six intercostal spaces, and that is going to come from the subclavian as well. There's going to be a subclavian, a branch coming out of it called the internal thoracic artery, and that's going to give intercostal arteries for spaces 1 until 6. طيب. Then, for spaces 7 until 9, the internal thoracic artery is going to give a branch called the musculophrenic. If we zoom in, ignore how blurry it is, but this is the musculophrenic branch. This is the internal thoracic, becomes the musculophrenic, gives us the anterior intercostal arteries for intercostal spaces 7 till 9. طيب. You're probably wondering what happened to 10, 11, and 12. Now, the thing about 10, 11, and 12 is do you think they occupy as much space anteriorly as the other ribs do? I would say no, okay? So because they do not, what's it called, occupy a lot of space anteriorly, they do not need anterior intercostal muscles. And so the posterior intercostal muscles are enough. Intercostal arteries are enough. I said muscles, I'm sorry. Okay? Are the anterior intercostal arteries clear? Okay. Now, the musculophrenic branch of the internal thoracic not only supplies the intercostal spaces 7, 8, and 9, it also can go down and supply the diaphragm. Yes, for the anterior intercostal arteries, all of them originate from the subclavian. We have the subclavian, internal thoracic, gives intercostal arteries from 1 to 6, and then we have a musculophrenic branch from it, and that gives for intercostal spaces 7 till 9. Are we good? Okay, so let's move on. We have the internal thoracic artery, right? I just told you it gives us the anterior intercostal arteries from 1 to 6, بعدين musculophrenic, بعدين 7 to 8, 7 to 9. طيب, I want to talk about the rest of its branches. We talked about the anterior intercostal. Now, we have perforating arteries from the anterior intercostal. This is not technically a branch from the internal thoracic. This is from the anterior intercostal. These perforating arteries, what they do is that they perforate and they supply portions of the skin and breast tissue, aka the mammary glands, of the specific area that they're going to. And then we have the pericardiophrenik artery. That artery comes from the top, okay, from the internal thoracic artery from the top. From the name, what does it supply? It supplies the pericardium and the phrenic, aka the diaphragm. Anything that says phrenic means diaphragm, okay? Fine. Then we also have the superior epigastric artery, and this is, we can see it's right here. Yeah. So you see this musculophrenic, this is intercostal space 7, 8, and 9, and we have this long artery going down. This one's the superior epigastric artery. What does it do? It pierces the rectus sheath, okay, which is a fibrous kind of tissue-like covering of the rectus abdominis, which is the main muscle of your abdomen. It pierces that sheath and supplies the upper portion of the rectus abdominis, okay? And then obviously you have the musculophrenic. It supplies the 7, 8, 9 intercostal spaces and the diaphragm. Are we good? Fine. Now we're going to talk about the coarctation of the aorta. Coarctation means narrowing, okay? When I say coarctation of anything, it's probably going to be narrowing. Coarctation of the aorta is congenital narrowing of the aorta. Keep this in mind. It is distal to the openings of the subclavian artery. It is distal to the main thoracic, to the main branches of the aorta. So let's zoom in, okay? This is the aorta, صح? This is the arch of the aorta. This is the brachiocephalic trunk going to the right side. This is the left common carotid. This is the left subclavian. The coarctation has to be after the main branches, okay? Why? Because one of the main clinical findings of coarctation of the aorta is the fact that these patients are going to have higher blood pressure in the upper limbs compared to the lower limbs. Now, why is that? Because we know that these branches, the brachiocephalic trunk, which eventually gives the right common carotid and the subclavian, and then we have the left common carotid and left subclavian, all of these branches, what do? They supply the upper limbs, the head and the neck with blood, okay? But we have the coarctation after them. So the thoracic and the abdominal aorta, everything that is supplied under these branches, like the lower limbs and the abdominal organs, everything else, they're not going to receive as much blood supply. If you're not receiving as much blood supply down there, okay, you're going to have a lower blood pressure in your lower limbs. Now, when they say high blood pressure here, this is kind of like a misnomer. It is kind of telling you, hey, this patient has hypertension, but no, they don't. The blood pressure that they have in the upper limbs is actually normal, but it's higher in comparison to the blood pressure they find in their lower limbs because of the lack of blood supply there. Okay? Is this concept clear? Okay. Like one very characteristic X-ray finding of coarctation of the aorta is rib notching. So let's zoom in. You can see, these are the ribs, okay? They're going to be wider than everything else because they are bone, and that's how bones show up on X-rays. You can see there's like a little notch here, a little notch. There's also kind of like a notch here, one here, one here. This is very characteristic of coarctation of the aorta. Right. Now, how does the body compensate? Because I told you, we have less blood supply in the lower limbs. Obviously, our body's like, this is so not okay. How do I make things better? It makes things better through things called collaterals. Collaterals all are alternative blood vessels that form, okay, to supply the area that is lacking. Okay. So where are these collaterals going to come from? They're going to come from this anterior they're going to come from the intercostal arteries, the anterior intercostal arteries, and they're going to go and form collaterals with the thoracic aorta. Okay. Why are they coming from the anterior intercostal arteries? Where did I tell you the anterior intercostal arteries came from? The first, the first six. Where do they come from? Internal thoracic. Okay. Internal thoracic of subclavian. Awesome. So the subclavian artery, we said that the coarctation happens after it. So the blood supply to the subclavian is not affected, meaning that the blood supply to the internal thoracic to these anterior intercostal arteries is not going to be affected. So that's where the collaterals are going to form and they're going to dump blood into the rest of the aorta that is not receiving as much. But now we're going to move on to the superior vena cava. I want you to focus on the posterior intercostal veins here, okay? This is the superior vena cava, and the posterior intercostal veins are the ones with red points on them, okay? Everything that doesn't have a red point on it is not posterior intercostal vein. Like this is the superior vena cava, and this is the brachiocephalic vein, okay? And we also have the subclavian veins as well, and they all drain into the superior vena cava. طيب. Now, for the posterior intercostal veins, look at them, okay? Let's zoom closely. This is posterior intercostal vein. This is another one. This is another one. This is another one. They're all going to drain into this one vein. This one is called the azygous vein, okay? The azygous vein eventually drains into the superior vena cava. طيب. On the other side, these are all the posterior intercostal veins. They're going to drain into the hemiazygous, into this hemiazygous vein. This hemiazygous vein will immediately drain into the azygous vein, or sometimes immediately drain into the brachiocephalic into the superior vena cava. So, are the posterior intercostal veins clear? Okay, awesome. I keep on looking in this direction because the chat is right here, in case people were like, why is she looking there? Okay. Now we're going to move on to the anterior intercostal veins. Now we're looking at the ones that, again, have a red point on them. These are the ones that are anterior, okay? Just like we had in arterial supply, we also have an internal thoracic vein here, okay? Now this internal thoracic vein, it's going to drain into the superior vena cava. And all the anterior intercostal veins are going to drain into it and eventually drain into the superior vena cava. And just like arterial supply, we also have this musculophrenic vein, which is going to drain into the internal thoracic, eventually drains into the superior vena cava. Is this clear? Awesome. This is a clearer picture of the musculophrenic in case you couldn't see it here because I almost missed it. So I kind of drew it out. I know the picture itself is blurry. Just follow the yellow and the red, okay? So this is the internal thoracic vein. It drains into the brachiocephalic vein into the SVC. The musculophrenic vein drains into the internal thoracic above, okay? Now we're going to move on to the lymphatic system of the thorax. Like, what is lymphatic system? It is a network of lymph capillaries, vessels, nodes, all that drain all the junk from your body. Extracellular fluids, toxins, and things like that all drain into the lymphatic system. Where does the stuff in the lymphatic system go? To the veins. Okay? Like, now, lymphatic system of the thorax is very, very important because majority of it is for the rest of the body as well. Let's talk about the right side. On the right side, we have this thing called the right lymphatic duct that drains 1/4 of the body, as you can see. That 1/4 is going to be the right upper limbs, the right thorax, and the right head and neck. Those are all going to drain into this angle of the subclavian. Okay? So this is the internal jugular vein, and this is the subclavian, and it's going to drain into there. Like on the left side, we have this huge portion of the lymphatic system called the thoracic duct. This is going to drain 3/4 of the body. We have the entire abdominal and pelvic cavity, all the lower limbs, the left side of the thorax, the left upper limb, and the left side of the head and the neck. And those are all, again, going to drain into the angle of the subclavian. Fine. This is just another picture of it. Now, where does the thoracic duct start? It starts at this dilation called the cisterna chyli. Cisterna chyli, it's going to go up, okay? But what's important here is what direction or where is it sitting, okay, in relation to the aorta. So we all know that the aorta kind of lies on the left side, right? We can see that this thoracic duct, it goes up on its right, okay? Now, this is important, and bear with me because it might get a little bit confusing, but it's important for later on, right? You see this thoracic duct, like it kind of does a little تكسر, okay? So it kind of breaks and it kind of goes more to the left, okay? Now here's the thing. It goes towards the left. Why? Because it needs to drain into this angle right here, this venous angle. Now, what is behind the trachea? Does anyone know what structure could be behind the trachea? Esophagus, exactly. طيب, let's follow this thoracic duct. It's to the right of the aorta. It does a little turn, does a little break, and then it drains into the thoracic insertion. If the esophagus is behind the trachea, is this thoracic duct now to the right or to the left of the esophagus? Left. Good. Yes, it is now to the left. So if I tell you, the thoracic duct starts at the cisterna chyli, it runs up in the posterior mediastinum to the right of the aorta. Then it becomes to the left of the esophagus. I'm sure you guys, class, you get it. Okay? What does it drain? 3/4 of the body. We said the left thorax, left upper limb, left head and neck, abdominal pelvic cavity, and lower limbs. Okay? Now for the right lymphatic duct, again, 3/4 of the body, right upper limb, right thorax, right head and neck. And again, it drains into this venous angle right here. And that's it. Fine. Now we're going to start off with the nervous innervation of the thoracic cage. So is veins, arteries, and lymphatic system good? Awesome. So we need to understand the basics of the nervous system, which I did want to ask, have you guys taken things like RAMI? Have you taken a bit about the spinal cord before? Yes. Okay, خلاص. So this it should be fine. Okay. طيب, this is the spinal cord. What? Everything. Whoa, everything. That's crazy. I don't remember taking that in first year. طيب. In the vertebrae, where did I tell you does the spinal cord pass through? Which part of it? Foramen. Yes. حلو. So the spinal cord passes through the foramen, and from each foramen, there's tiny other spaces on the side, and that is where your spinal nerves are going to come out, okay? So this is the anterior view. So this is going to be the anterior portion of the spinal cord, and the one behind it is going to be the posterior. Anteriorly, we have the anterior roots, but then posterior roots. They come together to form this, which is the spinal nerve. Now, the spinal nerve, it divides into rami. We have the ventral rami, aka anterior rami, and we have the posterior ones. The posterior ones, what do they supply? Skin in the back, muscles in the back, all that kind of stuff. The ventral rami, they're going to go and they're going to form the intercostal nerves. Okay? طيب. The brachial plexus, I'm sure you guys, and someone answered C8, okay, as a part of the brachial plexus, so I'm sure you've kind of seen it before or taken it before. You know what a plexus is? Collection of nerves that come together to supply a certain part of the body. These spinal nerves will not form a plexus. You have to keep that in mind. They do not form a plexus. If they formed a plexus, then we would not have individual intercostal nerves, okay? طيب, let's talk about these ventral rami. These ventral rami, they're going to go, okay? Every spinal nerve is going to go to a certain part of the body and supply it. So we're going to get dermatomes and myotomes. Dermatomes and myotomes are a portion of the skin and a group of muscles that are supplied by a singular spinal nerve, okay? A few dermatomes that you should keep in mind are T10 for the umbilicus, not for CVP specifically, any, but for later on, and it's good to know. T10 for umbilicus. For CVP specifically, you have to note that T4 is the area of the nipples. I think that's it. I think, yeah. But now we're gonna move on to typical and atypical intercostal nerves because they love being very nitpicky. فنow, typical intercostal nerves, let's break it down step by step. طيب. We have the rami, okay? Ignore gray and white. I don't care if you know that or not. We have the rami. They communicate with the sympathetic trunk, okay? Does anyone know what the sympathetic trunk is? Or the sympathetic ganglion or whatever? Tell me, what does sympathetic anything mean? Okay, okay, someone said, okay, fight or flight. Okay, good. Part of autonomic, yes. طيب. Okay, I think this is enough. Yeah. So you're aware that the sympathetic nervous system is responsible for fight or flight. Okay. So good way to remember this is imagine you're running away from a lion. What do you want to do? You want to see more. You want to poop less. You want to pee less. So sympathetic nervous system kicks in. طيب. Part of typical intercostal nerves is that the ventral rami is going to communicate with the sympathetic column or the sympathetic trunk. طيب. Now, the other portion of the typical intercostal nerves is that they have cutaneous branches. Cutaneous, anything cutaneous means skin. So, and supply the skin, anterior lateral branches. But then we have the muscular or the motor branches, which are going to supply the muscles of the intercostal muscles and the anterior abdominal wall. And lastly, we're going to have collateral branches. Now, collateral branches, all they do is help out. Okay, so what are they going to do? They're going to help out with the supply of the intercostal muscles and the parietal pleura. Again, pleura is the covering of the lungs, and those are partially going to be supplied by these collateral branches. How do these collateral branches run? This is a singular intercostal nerve. This just came out. This is the ventral rami intercostal nerve. This is probably lateral cutaneous, but then this is anterior cutaneous. But we're going to get this collateral branch. It's going to go under the rib that it just came from, and to the superior portion of the rib under it. Okay, that's basically their course. طيب. Now for the atypical, okay, yeah, so typical intercostal nerves are T3 to T6, okay? So atypical, what are they going to be? T1, 2, 7, 8, 9, etc. Okay? Typical are going to be T3 to T6. I'm going to test you guys about this later, so remember it because I forgot to mention it last طيب, atypical intercostal nerves, we said T1 to T2, T7, and T12 until T12. T7 and T12 were not mentioned in the lecture, and so I will not go into detail about them. I will not go into them, period, because the only ones that I saw in Dr. Elena's lecture were T1 and T2, okay? Fine. For T1, why is it atypical? It gives a branch to the brachial plexus. Typical intercostal nerves do not give branches at the brachial plexus, but since this is T1, we already mentioned it in thoracic outlet syndrome, it's going to give a branch to the brachial plexus. T2 is, it kind of follows a similar issue where it's going to give this intercostal brachial nerve, which is going to join the median cutaneous nerve in the arm, which is in the brachial plexus. So technically, the intercostal brachial nerve branch from the T2 spinal nerve will also form the brachial plexus, making it atypical. Are we clear? Awesome. Let me change the position of this phone. Okay. Okay. Awesome. طيب. Clinical application of this is that referred pain from coronary artery disease, MIs, stuff like that. The patients are probably going to tell you, "Oh, I feel this like really weird pain on my arm." This is because of these branches of plexus also follow the same path of the sensory fibers from the heart. Okay, so that's why they get referred pain on their upper limbs. But now another very important nerve is the nerve. What did I say about phrenic? What does it supply? Diaphragm, exactly. So the phrenic nerve, okay, it doesn't come from the T's. It doesn't come from the thoracic vertebrae. It doesn't come from the thoracic spinal cord at all. I completely forgot the word cord. It comes from C5 and C6, your cervical spinal nerves, okay? So it's going to come from C5, C6, and I want you to take note of how it runs, its course, okay? I highlighted the scalene muscle. Remember, there was a scalene tubercle on rib number one. That's where it attaches. This is the scalene muscle, okay? You don't need to know it in detail. Just know that it's there. The phrenic nerve, it comes from C5, C6 and passes anterior to the scalene muscle right in front of it, okay? And it goes anterior to the root of the lungs. What is the root of the lung? The root of the lung is also called the hilum of the lung. That is where you get the bronchus going inside the pulmonary veins and the arteries. That's where they go inside. We're going to call that the root, okay? So the phrenic nerve from C5, C6 goes anterior to the scalene muscle and then anterior to the root of the lung, okay? What does it supply? It supplies the pericardium. It gives the pericardium sensory supply, and it also gives motor supply to the diaphragm. It is accompanied by the pericardiophrenic branch of the phrenic nerve, pericardiophonic branch, because it also supplies the pericardium. Okay, and I added the line here to show you the pericardial branch. Play. Now the vagus nerve. This is what the vagus nerve looks like in total. We're not going to go into this. I put this here to show you how huge it is. Okay, how important it is. The vagus nerve supplies parasympathetic supply to majority of our organs in the thorax and abdomen and in the pelvis sometimes, okay? طيب, you said that sympathetic was fight or flight, so parasympathetic is rest and digest, okay? So now let's talk about the branches of the vagus nerve. We have the esophageal plexus. It goes and supplies the esophagus. بعدين, it pierces the diaphragm with the esophagus, okay? See how it pierces the diaphragm? And it forms two vagal trunks on the stomach. We have an anterior or a ventral vagal trunk and a posterior vagal trunk on the stomach. You need to know that the anterior vagal trunk, it ends on the stomach, okay? خلاص, it pierces the diaphragm, gets on the stomach, and that's it. The posterior vagal trunk, it's going to continue down the abdominal aorta, and it's going to join this group of arteries that you're going to take later in GIT, and it's going to form the celiac plexus. What does the celiac plexus do? It supplies organs of the upper abdomen. Okay. Now, another important branch of the vagus nerve, I'm pretty sure you've been hearing about this over and over and over again, are the recurrent laryngeal nerves. Okay. We have a left and we have a right. So this is your vagus nerve. It goes down. This is the left recurrent laryngeal nerve. Okay. I want you to see and notice how it literally hooks under the arch of the aorta. Okay. It hooks under the arch of the aorta and then it comes back up. And this is why they call them recurrent. They're recurrent because they come back. Okay. That's the way that I remembered it. And then for the right recurrent laryngeal nerve, it doesn't hook under the arch of the aorta because it virtually and physically cannot. Instead, it's going to hook under the subclavian artery, the right subclavian artery. Is it clear so far? Awesome. Now, this is the right recurrent laryngeal nerve. It hooks under the subclavian. Again, the left one, let's just recap, hooks under the arch of the aorta. What do they supply? They supply the intrinsic muscles of the larynx, okay, except the cricothyroid muscle. This is the cricothyroid muscle. This is the subclavian. Yeah, this is gonna be which one, the right or the left? If it's hooking under the subclavian. Right, perfect, yes. And the left one hooks under the arch of the aorta. Awesome. So the right recurrent laryngeal nerve goes up and it supplies most of these muscles except this cricothyroid muscle, which is supplied by this superior laryngeal nerve. Okay? That's all you need to know for now. Now, remember dermatomes and myotomes? طيب. I want us to all go back to when we were 5 or 6. I never had chicken pox, but I'm pretty sure some of you did. And if you did, okay, and this obviously isn't as scary, it's just a possibility, you might be at risk of toxin in adult life called shingles is a complication of where the varicella zoster virus, which is chickenpox itself, it's going to sit in the spinal ganglia of your nerves. It just said my connection is unstable. Can you guys still hear me? Okay, thank God. Phew. Yes, but lagging? Okay. Let me know if it continues lagging. I'll connect to my hotspot. طيب. So the varicella zoster virus is the one that causes chickenpox, okay? Sometimes this varicella zoster virus, it can sit in your spinal, okay? What is it gonna do? Nothing. For years, it's gonna do nothing. And then it's gonna have a trigger later on. It's gonna okay, it's gonna reactivate and it's gonna cause shingles, aka herpes zoster infection. طيب. Why am I saying all this? Why did I mention dermatomes and myotomes? Because it was sitting at a specific spinal ganglion, it will only affect the dermatome that is affected or that is supplied by that spinal nerve. So I can't really point out, but I'm assuming that this is probably going to be something like T8 or T10, maybe. Okay, so this means that this person's varicella zoster, when they were a kid, they were like, hey, I really like this T8 spinal nerve. I'm going to sit here and wait. And so when they grew up, they became adults, they get shingles, and it's going to affect that certain dermatome. Are we clear? Awesome stuff. طيب. Now we're going to move on to the mediastinum. Last part of this lecture, alhamdulillah, and I hope everything's been clear so far. We're going to get into this and we're going to finish it quickly because it's very simple, inshallah. طيب. Before I go into it, I already mentioned the mediastinum before, okay? And I mentioned it when I was talking about one of the bones in the thoracic cage. Can someone remind me what it was? Sternum. Sternal angle. طيب. Let's do a little recap. Sternal angle is at the level of which vertebrae? T45. I told you it marks three different things, okay? Tell me the two things that it marks, T4 and T5. Tell me the two things that it marks, and what does it have to do with the mediastinum? Rib 2, okay. Internally, what does it mark internally? You're correct, but what does it mark internally? End of arch of aorta and bifurcation of the trachea. Awesome. What else relating to the mediastinum specifically? Mark superior and inferior. Awesome. حلو. So now we are good. I feel like we are good to start with mediastinum. طيب. What is the mediastinum? It is the central compartment of the thoracic cavity. Basically, anything that is not the lungs and the pleura of the lungs is considered to be the mediastinum. Okay? So in between them, this is the mediastinum. Anteriorly, what do we have? We have the sternum. We're well aware of that now. And the costal cartilage. We're very comfortable with them. Posteriorly, we have the vertebrae. Superiorly, we have the thoracic inlet. And inferiorly, we have the diaphragm. Okay? طيب, let's split it up. I told you sternal angle. We have the superior mediastinum and the inferior mediastinum. طيب, let's split the inferior mediastinum into different compartments. We have the anterior, which is this purple one, the middle, the yellow one, and the posterior, the blue one. Okay? طيب. Now, for the superior mediastinum, anteriorly, we have the sternum. Uh, okay, I don't think they want the sternum here. Okay, خلاص, whatever. In the superior mediastinum, anteriorly, we have the thymus gland, which is this. Okay, this yellow thing right here, that's the thymus. Okay, and or whatever remains of the thymus. Why am I saying whatever remains of the thymus gland? Because the thymus gland is not completely there in your adult life. Okay, you kind of lose it after puberty. Okay, طيب, in the middle of it, what do we have? We have the arch of the aorta. Okay, so you can't really see the arch of the aorta. طيب, what you can see are the branches of the aorta. But technically, because it's a superior mediastinum, above it we said, the arch of the aorta starts and it ends. We have the arch of the aorta, tamam. And we also have the phrenic nerves. So we have the vagus right here, okay? This is the right vagus, this is the left recurrent laryngeal, this is the phrenic, okay? Why do I know that this is the phrenic? Or where did I tell you the phrenic passes? In front of everything else. Awesome, طيب. I mentioned two things that it passes in front of. What are they? The first one, tell me, give me the first one. In front of the root of the lung and the one on top, scalene muscle. Awesome. So, yeah, so we're good. And then the vagus nerve, I told you here, left vagus, but then this is the right vagus, and this is the left recurrent laryngeal, okay? Um, and this is the left phrenic nerve, obviously you have two. طيب, and posteriorly, what do we have? We have the trachea and we have the esophagus right here. the recurrent laryngeal nerves, and the thoracic duct. This is the thoracic duct right here. And okay, I told you the thoracic duct. Okay, so if we continue moving superiorly, I told you that the thoracic duct moves to the left of the esophagus, right? So if I continue moving upwards, this is eventually going to move in this direction and drain into which area? Oh, okay, my bad, my bad. So I thought, okay, whatever. So the left, not the left, the thoracic duct, okay? I told you, it starts from the cisterna chyli, right? It goes up and it's on the right side of the aorta. It goes up, eventually becomes the left side of the esophagus, okay? But I want you to tell me, where does it drain? Yeah, the thoracic duct drains into the venous system. Where in the venous system does it drain? Root of brachiocephalic vein. Okay, makes sense. Um, root of brachiocephalic vein is technically not wrong, but I highly suggest you say subclavian angle or venous angle instead. Okay, venous angle of the subclavian vein. Much better than saying root of brachiocephalic vein, okay? طيب. So let's recap this. Anteriorly, we said we have the thymus gland, okay, and we have the great veins, اللي هم the left brachiocephalic and the right brachiocephalic. Those are the veins that drain into the SVC. In the middle, we have this is the brachiocephalic artery, left common carotid, and the left subclavian artery. Yani technically, we have the arch of the aorta. We also have the phrenic nerves, which is this right phrenic nerve and the left phrenic nerve right here, and the vagus nerve. This is the left vagus nerve. This is the right vagus nerve. طيب. Posteriorly, we have the trachea and the esophagus, and we also have the left recurrent laryngeal and the thoracic duct. طيب. Now, moving on to the clinical importance of the superior mediastinum. The anteriorly of the superior mediastinum, what do we find? We find the manubrium of the sternum, right? What did I tell you we can do at the sternum clinically? Puncture, exactly. So we can do a bone marrow biopsy or sternal puncture. Okay. Now imagine that I'm not that experienced. I go in too deep. What's right behind it? The brachiocephalic veins, the left brachiocephalic, and if I go deeper behind it, we have the branches of the aorta. So it's very, very important that you understand what is in the superior mediastinum in case you're ever going to do a sternal puncture, because injury to any of these vessels and structures is a huge emergency. All right. طيب. Then we're going to move on to the inferior mediastinum. We have anterior, middle, and posterior. طيب. Anteriorly, we have the thymus, fat, and lymph nodes. Again, thymus, it is a lymphoid organ. What is a lymphoid organ? It is where the lymphocytes or WBCs in your body mature. So we have these things called T cells. T cells do not become T cells magically or overnight. They have to mature into T cells. And the thymus is usually where they're going to do that. But the thing about the thymus is that it involutes or disappears after puberty, okay? You also have a bunch of fat and a bunch of lymph nodes. That's for the anterior mediastinum in the inferior mediastinum, okay? In the middle, I color-coded them for you. We have the heart with its pericardium. We have the roots of the great vessels. So we have the aorta, the superior vena cava. This is the right pulmonary artery, and this is the right pulmonary vein, okay? Both of these. And then we also have the phrenic nerve. Again, I told you, oopsie, one second, one second. Okay. So the phrenic nerve, imagine this is the scalene muscle right here. It passes in front of the scalene muscle, in front of the root of the lung, because this is the root of the lung, right? So it's going to pass in front of it. So it's just a schematic diagram to show that to you. And then we also have the main bronchi. And lastly, the arch of the azygous vein. Can someone remind me what drains into the azygous vein? What veins did we take drain into it? Hemiazygous and also, yes. And what else? Hemizygous and accessory hemizygous. Okay. Posterior intercostal. That's the answer that I was looking for. But you guys are completely correct. Okay. طيب. So that's for middle mediastinum. I'm pretty sure it's pretty clear and self-explanatory. So let's move to the posterior mediastinum. Two pictures because we have two different sides. طيب. What do we find? We find the esophagus. This muscular thing, this muscular line right here, that's the esophagus. Okay. We also have the descending thoracic aorta right here. And its branches like the posterior intercostal arteries, right, from 3 to 11. And then we also have the azygos and the hemiazygos. So the azygos comes out from the right side of the superior vena cava. So we're going to see the arch of this azygos vein as well. But this arch, again, if they ask you, arch of the azygos vein, where is it? Middle mediastinum. The azygos vein itself, the part of it that goes downwards, right? That's in the posterior mediastinum. And we can also see the hemiazygos vein. The hemiazygos vein is this one right here, this blue line. That's the hemiazygos. What else can we see? We can see the thoracic duct. You can barely see the thoracic duct. Why can we thoracic duct here? Because we can see the esophagus. What is the relationship between the thoracic duct and the esophagus? Left. Okay. So we're looking at the right side. Obviously, we're not going to see the thoracic duct because it's to the left of the esophagus. Okay. And lastly, we can see the sympathetic trunk, which I told you the what's it called? The ventral rami that give the intercostal nerves, they join the sympathetic trunk as well. And the splanchnic nerves. Great splanchnic nerve right here. Okay. Hello. Now the venous system, this is pretty simple. We already did this. This is the superior vena cava. We have the left brachiocephalic vein draining into it with the internal jugulars draining into it. But we also have the azygos vein draining into the superior vena cava. And as you guys very rightfully mentioned before I even mentioned it, the accessory hemiazygos and the hemiazygos draining into the azygos, which drains into the superior vena cava. Okay? And highlighted this, just remember this is where the thoracic duct drains, okay? حلو. Okay. Now for the azygos nervous system, I already mentioned the azygos is on the right side, okay? It drains into the superior vena cava. And what is it composed of, or what drains into it? The accessory hemiazygos and the hemiazygos itself, okay? And also it drains blood from the posterior intercostal veins as well. حلو. It also drains blood from the posterior abdominal wall, the pericardium, the diaphragm, the bronchi, and the esophagus. Not join the SVC, or doesn't drain into the SVC. It drains into the azygos, which drains into the SVC. Can you guys still hear me? It just was unstable. Okay, good. We're nearing the end. Trust. It's lagging now. Is it lagging enough for under? Well, can you still understand me? Okay, I'm just gonna assume. Okay, we can understand. Okay. It gets bad for a few seconds. Do we have to know what intercostal spaces are drained by superior and inferior hemozygous vein? No, 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 you don't. No, you don't. No. Doctor, she only mentioned that a specific part of it, خلاص, it drains into the hemizygous vein, and that's all you need to know. Okay? Yani whatever was mentioned about the posterior intercostal veins, that's all you need to know. Okay? Don't go into the specifics. Okay? Okay. Now we're gonna move on to the inferior vena cava. Okay? So we talked about the superior. This is the superior. This is the inferior vena cava. This is a posterior view of the heart. Okay? Uh, where does it drain blood from? Everything under the thorax, the abdominal cavity, pelvic cavity, lower limbs, everything there drains in IVC. The IVC obviously has to pierce the diaphragm at the level of T8. Okay. Inferior vena IVC pierce diaphragm at the level of T8. Okay. And then we also have the pulmonary veins. This is again posterior view. Pulmonary veins, they carry oxygenated blood coming from the lungs back into which atrium? Left. Awesome. Awesome stuff. طيب. Okay, and we move on to the aorta. The aorta has three different, yes, left atrium. The aorta has three different segments. We have the ascending aorta, the aortic arch, and the descending aorta. Okay, the descending aorta is divided into the thoracic descending aorta by the diaphragm. Okay, aorta we're not going to be talking about. This is going to be for the tutor. We have Abdulrahman Alabyad. He's going to be talking about cardiac anatomy. We have the right and the left coronary arteries. And then we have the arch of the aorta, where we get the brachiocephalic trunk on the right, which gives us the right and the left, the right subclavian and the common carotid. And then on the left side, we have the left common carotid and the left subclavian. Okay. And then we want to talk about the aortic aneurysm before we move to the descending aorta. What is an aneurysm? The opposite of a coarctation, abnormal expansion. The most common site in an aorta for an aneurysm is the arch of the aorta. Now, remember, what is the thing that passes and hooks under the arch of the aorta? Left recurrent laryngeal. Awesome. So, if the aorta it currently has an aneurysm, that left recurrent laryngeal nerve is going to get compressed. These patients are going to present with excessive coughing, hoarseness of the voice, and possibly paralysis of the vocal cords. Okay. What else is around the aorta? We have structures like the trachea and the esophagus and a bunch of other very important vessels and nerves. Okay. These patients can also experience dysphagia. This dysphagia is difficulty swallowing. Why? Because there's pressure and compression on the esophagus. Dyspnea is what's it called? Abnormal breathing. Why? Because it's phrenic nerve, مثلا. It's compressing the trachea. It's compressing the root of the lung and a bunch of stuff. Okay. This is important for one main reason, to be able to identify an aortic aneurysm in the clinic. Okay. طيب, aortic aneurysm, that is thoracic part of the aorta, okay, and a little bit under here, okay, in the beginning, first part of the descending. Here's what's going to happen. The aortic aneurysm is going to expand so much so that it's going to actually tug on the trachea and move it to the side, right? And instead of the trachea being right under the sternum, we're going to be able to feel the aneurysm itself. So if you palpate on the sternum, you can feel the aneurysm, or you can feel that expansion, okay? That's what this box is talking about, okay? Hello. Now for the thoracic aorta, first part of the descending, we already talked about most of it. We have the posterior intercostal arteries and the subcostal arteries. Posterior intercostal, we said no. Aorta, get the subclavian. From there, we get the costocervical trunk, which gives us the intercostal arteries for the first two spaces. And then we get a bunch of branches from this first part of the descending, or the thoracic aorta, to the intercostal spaces of 3 until 11. And we also get a subcostal artery from there as well. What else does it give? It gives superior phrenic arteries. They supply the diaphragm. We get pericardial, bronchial, and esophageal arteries as well. Fine. Now for the pulmonary trunk, what this, I'm not going to ask you what this is. This is, you obviously know this. This is the right ventricle. It goes up, it gives us the pulmonary trunk. The pulmonary trunk is going to give us the left and the right pulmonary arteries, which are going to go and supply the deoxygenated blood to the lungs to oxygenate them. Okay? طيب. Now, the clinical relevance here is that the pulmonary trunk and the arch of the aorta should be connected through this ligament called ligamentum arteriosum. Why should it be connected? For stability. Okay? Where does this ligamentum arteriosum come from? It comes from this thing called ductus arteriosus. Ductus arteriosus is a viable connection that you used to have when during fetal life that allowed for blood to mix between the aorta and the pulmonary trunk, okay? Or blood from the aorta to pool into the pulmonary trunk, okay? Imagine if the ductus arteriosus never becomes ligamentum arteriosum. It never becomes this fibrous band. What's going to happen? We're going to get PDA, or patent ductus arteriosus, where we have a viable connection between the aorta and the pulmonary trunk. Okay, what are factors that can cause this? And this is usually obviously going to present in kids most of the time. What can they have experienced during fetal life to keep this patent ductus arteriosus? Increased prostaglandin E and low oxygen or hypoxic environments in the womb. And PDA is very common in premature infants, so those that are born before 37 weeks of pregnancy, or after a maternal rubella infection. Rubella is just bacteria. And what else is written here? Okay, so the aorta, it comes from the left side of the heart, right? The pulmonary trunk, it comes from the right side. طيب, here, there's going to obviously be a lot more pressure in the aorta than there is in the pulmonary trunk. So the blood is going to come from the aorta to the pulmonary trunk. And since the aorta is on the left, the pulmonary right, this is going to be a left to right shunt, okay? Left to right shunts are not characterized by cyanosis. Okay, why? Because the aorta is supplying oxygenated blood. That's it. Okay, there is no deoxygenated blood going into the aorta. So the patient is still fine in terms of oxygenation. It's just a bunch of pressure going to this pulmonary trunk that can later on affect the lungs. When it affects the lungs, we're going to call this pulmonary hypertension. And make sure that these patients will be non-toxic. Okay. Treatment of this is going to be surgical division and ligation of this patent ductus arteriosus. And as you guys already mentioned, the left recurrent laryngeal nerve passes under it. And so the surgery can possibly damage it, and these patients can present with a hoarseness, excessive cough, etc. And now lastly, lastly, we have the esophagus. This is just a muscular tube from the mouth down to the stomach. We can divide it into three parts depending on the kind of muscle that is in it. Superiorly, we have skeletal muscle. Inferiorly, or in the last third of it, we have the smooth muscle. And in the middle third, we have a transitional muscle from skeletal to smooth, okay? It pierces the diaphragm at the level of T10, and it starts at C6, okay, level of the cricothyroid. And this is a summary of the openings in the diaphragm. We mentioned in the esophagus, I just said it, opens or pierces the diaphragm at the level of T10. The aorta pierces the diaphragm at the level of T12, and the right nerve and the inferior vena cava at the level of T8. And that brings me to the end of the lectures, and we are going to start with a couple of questions now. I'm going to read them out, and I just want you guys to put whatever answer you think is correct in the chat, okay? But we have a man that has complained of changing of his voice. Which of the following nerves might have been damaged leading to this change? Yep. A, exactly. Because left recurrent laryngeal nerve, it supplies the intrinsic muscles of the neck, including the vocal cords. Damage can cause paralysis and hoarseness of voice. By the way, these questions are from past papers. I think I used 16th batch. Well, I think I took one from 15th. I'm not sure. Okay. Hello. Question number 2. A man developed a tumor in his posterior mediastinum. Which of the following is probably compressed? C. C. Okay. Who else? C. Okay. So you're correct. It is C. The arch of the azygos. And we saw it. We literally saw it. It's on the right side of the posterior mediastinum. صح? طيب. Why am I doing this for this question? It's pretty simple. It's pretty straightforward. I included this question because actually, I think I took this from, I want to say 17th. I'm not sure. Okay. Just if you're going through past, check it. In the past paper, they answered Vegas, but we know it's not Vegas, right? Let's go back just so we can confirm for my and your own peace of mind. We can see this is the arch of the azygos. This is the posterior mediastinum, صح? Where's the Vegas here? The Vegas is right here. It's in front of the aorta. Isn't the arch in the middle? Exactly. No, wait, no. The arch of the azygos is in the posterior mediastinum. It's right here. This is the superior vena cava. This is the arch of the azygos. Oh, oh, I see. Okay. This is a little bit embarrassing. So the arch of the azygos is in the middle. The azygos itself is in the posterior. That's why I got confused. My bad, guys, my bad. But then again, the vagus nerve is still not the correct answer, but that's what was in the past. Okay, so here's what I'm gonna do. Let's just ignore this for a bit. Yeah. Let's just keep it as it is. Okay. So according to your past paper, the answer here is A. Me personally, I do not agree, but that's up to you guys to decide. Okay. So a man develops a tumor in his posterior mediastinum. Which of the following is probably compressed? The vagus nerve. I apologize for answering the arch of the azygos. You guys are very correct and very observant. The arch of the azygos is in the middle. The azygos itself is in the posterior mediastinum. My deep apologies. Question number 3. A 68-year-old man developed a tumor anterior to the hilum of the lung. What is it most probably compressing? A. 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 Okay. So you guys are correct. It is the phrenic nerve. Why? Because we said the phrenic nerve from C5, C6, anterior to the scalene, anterior to the root of the lung. Awesome. Question number 4. This is an SAQ. I think this is from 17th. Patient presents with hoarseness, dyspnea, and fatigue. X-ray shows a left bronchi bronchogenic carcinoma. What does hoarseness tell us about the location of the density in the X-ray? Just give me a random answer in the chat, so I'll show you the one that I wrote up, the official one. You feel me? Okay, near larynx, not quite. Okay, so the answer, okay, is that the fact that this patient presents with hoarseness and all that kind of stuff, is it near? Yes, it is near the left recurrent. So they present with hoarseness, right? So this suggests that, hey, on X-ray, the tumor is probably going to be located near the left hilum or the mediastinum, okay? Why? Because that's where it can compress the left recurrent laryngeal, and that's what causes the hoarseness of the voice. Is this clear? Awesome. We have one more question left after five. What are the two structures that get compressed by the cervical rib? Pretty simple. We said it. Yes. Awesome. And question number six. Patient with chronic angina. There are pulsations at his left fifth intercostal space, mid-clavicular line. What structure can be palpated in this area? C. Yes, the apex of the lung, the apex of the lung, apex of the heart. This is kind of this is a very cute question coming from the College of Medicine. They write apex to try and confuse you. Oh, apex of the heart or of the lung, but obviously this is going to be apex of the heart. All right, and with that, I thank you guys so much for attending my session. I hope this was helpful, and I apologize for the question number two shenanigans. Well, I didn't mean it. But it would mean the world if you guys can scan this QR code and give me feedback, and this helps the PAL team a ton. And if you have any questions or concerns, here's my contact information. And yeah, I hope you all have an awesome evening, inshallah. Anytime, anytime.
Uh, is it recording? Okay, here we go. Assalamu alaikum, everyone. My name is Abdulrahman. I'm a fifth year medical student, and today we'll be discussing the anatomy of the heart. So, inshallah, it's three lectures that we'll be talking about the circulation of the heart, the external anatomy of the heart, and the internal features of the heart. And if you have any questions throughout, you can type in chat, you can unmute your mic, and you can let me know. Okay, so to begin, let's take it from outside to inside. So Rafa previously just explained to you guys the chest anatomy of the thoracic cavity, right? So now what I'm gonna be talking about is the heart. So basically, if you should know, let me lower up my camera. So the heart is basically, or the chest is divided into two main chambers, the pleural spaces, which is gonna have the lungs, and then inside it is the mediastinum. Mediastinum is where the heart is located, okay? So this is just for our basic external anatomy that we need to keep in mind. And so the entire conversation that we're going to have right now is going to be in this mediastinal area where we have the heart. Okay, so to begin, first of all, let's talk about outside. How is the heart located outside? Where is it located? And what's the importance of the location of the heart from outside? Now, as we said, the heart is located in the mediastinal area. And usually we hear that the heart is on the left side, the heart is in the middle. Truthfully, the heart is actually partly on the right, mostly in the middle, and then another big chunk of it is on the left side. So you can see it's 1/3 in the middle with a small part towards the right side, and then a big part of it is towards the middle and the left side. Okay. And if you want to discuss it anatomically, then you can say it's located between the T5 and the T9 vertebra. And what this means is that basically, if you go to the back side of the patient where the vertebra is going to be located, this around here is going to be the fifth vertebral level from the back, and then around here is going to be the ninth vertebral level. And so the heart is kind of in between that. So, just fun facts. Now, the important part that we want to discuss is the surfaces of the heart. Now, what is composing the anterior surface and why is it important? Because the anterior surface is the most superficial surface, which is going to be like basically if anything happens to the anterior part of the chest, let me lower the camera. If anything's happening towards the anterior chest, this is the anterior surface which is going to be damaged. And now this anterior surface is also referred to as the costosternal surface. Why? Because you have the sternum right here, and then you have the costal margins, which are basically these little parts of the ribs. Now this is the anterior surface, and it's composed of the right ventricle. The other really important surface that you need to be aware of is the posterior surface. The posterior surface is made by the left atria. And the way I remember it is that, you have to just remember one of them. If you remember that the anterior surface is by the right ventricle, and then the posterior surface is by the complete opposite one, which is instead of right, you have a left, and instead of a ventricle, you have an atria. And now why is this one is the most important two that we'll discuss that in a second. But mainly, I need you to remember these two. And now the other surfaces, which include your inferior surface, which is made by both ventricles, the superior surface, which is right here, which is around where the vessels are going to be coming out. And then you have the lateral surfaces. The right surface right here is going to be for your right atria. And then the left surface is going to be done by the left ventricle and partly the left atria. Okay? So the most important two I want you to remember are the anterior and the posterior. Now, I have a small mark here on the anterior surface because it has another name, which is the costophrenic surface. The costosternal surface, I mean. And then the inferior surface is the phrenic. The phrenic is basically the diaphragm. So the phragm is basically phrenic, so that's why it's referred to as the inferior surface. Now here I put for you another picture of the heart, which is basically, now you can see this is the right atrium, okay? And the right atrium is on the right side. This big chunk right here is all the right ventricle, and it's the anterior part. Now this right here is the left side. You see there is this part and this part. This is the left ventricle and the left atrium. The inferior part, we'll take a look in a second, and then this is the superior part. Now this is a lateral view. Why I put this picture is that because, maybe you'd say, or like for me at least, it would be confusing that we know that the left ventricle is actually the biggest chamber, right? But if you look right here, then you can see that the right ventricle is looking pretty big compared to the left, and it looks like it's occupying most of the area, right? Now, this is why I put the lateral side picture right here, because I want you to notice that the right ventricle, while anteriorly it might look big, however, you can see that it's basically like a small layer that's covering a big chunk right here, which is the left ventricle. So the left ventricle is actually the really thick white part, and then the right ventricle might appear big. However, it's basically this is not as big. It's big, but it's not as big as the left ventricle, which is basically this big chunk of ball sitting right there. Now, this is just in case you were confused about it. Now, here is other views that I put for you. Now, this anterior view is basically the same. So we have this, which is the right ventricle, the right atria, superior surface, the left ventricle. And now this is the posterior view. Now, where exactly do you think the left atria will be located? So if we said this is the left ventricle, this right here, this part is the left atria. Wait, 1 second. Let me just. Okay. So this right here is the left atria. You can see it's basically the entire posterior part. So if the heart is sitting right here, then the posterior part is basically completely made of the left atria, right? Now, this is a cross-sectional view. You can see the anterior surface is made by the right ventricle, and then the posterior surface is made by the left atria, okay? And now this is an inferior view. So inferiorly, you can see there is these two contributing, the right ventricle and the left ventricle. So that's why the inferior surface or the diaphragmatic surface is made by both. Now let's talk about the importance of this. Why do you really need to know these facts? Now, one of the important things is the point of maximal impulse, which is basically referred to as the apex beat. Now, the left ventricle is the strongest part of the heart, right? Because there is so much muscle. And so another important feature of it is that the apex, which is this small pointy part, so if this heart is sitting right there, then you see this right here, the apex is going to be located towards the outside. So this apex, which is going to be, this is the heart, this apex is seated towards, like under the nipple, which is referred to anatomically as the fifth intercostal space, mid-clavicular line, right here, right under the nipple. And the apex is like almost touching the chest wall. And this is important because if you feel on it, if you put your hand right there, this is like the only place you can feel a strong pulse of your heart. And why exactly if it's there is because basically we said this entire thing is the right ventricle, but you see there is a small part of the anterior surface made by the left ventricle. And this small part is going to be located in the mid-clavicular line, fifth intercostal space. So that's why, this is the anatomical location of it. Now, the importance of the apex beat is like, why would we want to feel where the heart places or where this apex beat is? You can just measure pulse from here or measure pulse from your hands, right? But it's important because if this apex beat or the point of maximal impulse was dislocated to a different place, so for example, instead of being in the fifth intercostal space, it was right here, like towards the seventh intercostal space. What does this mean? It basically means that the heart is full, or the left ventricle is full of water. So this could indicate underlying, for example, heart failure, right? Because it's so full of water that the place of the apex beat has been pushed down. So the ventricle is expanded a lot. Okay, so this is one of the things that you can see. Another clinical importance is that some people have this underlying disease where basically the entire organs, or at least the chest cavity organs, instead of being on the left, they are on the right. So a person's heart, instead of being in its normal location on the left, there is a disease where the heart is going to be on the right. So if a doctor comes in and he's examining this patient, he's feeling for the heartbeat, he can't feel it in this place. And then he checks on the right side and he feels it, then he knows that this patient has this type of disease and he can base his understanding of what other complications he might have based on that. But this is just a fun fact that some people have their heart on the right side. And this is why we use the point of maximal impulse. Now, the two other important things are penetrating chest trauma and enlarged left atria. So remember how I said two important surfaces I need you to remember. The anterior surface, which was made of the right ventricle, and the posterior surface, which was made of the complete opposite, the left atrium. Now, since the anterior surface, the most anterior part, is made of the right ventricle, any patient that gets a stab wound to the chest, that gets a gunshot to the chest, what part of the heart is going to get damaged? The right ventricle, okay? And now this is why it's important. Now, on the other hand, the left atria, why it's important is that basically, if you look at this section right here, the left atria has all these structures around it, right? So if it's getting enlarged, if we have a big atria, what happens is that it's going to be starting to compress on these things. And one of the important things that it would compress on is the esophagus, which would lead to dysphagia or difficulty with swallowing because you're basically constricting the esophagus at that place. Hoarseness of the sound, which is there is a nerve called the left recurrent laryngeal nerve, which goes beside the esophagus. So if there is compression on that nerve, you're going to get hoarseness of the sound. And then the bronchi of the lungs. If you compress the bronchi, you're going to also have difficulty breathing. And then with some difficulty breathing, you can get a cough. So basically, I need you to remember that the left atria is the most posterior surface of the heart. The right ventricle is the anterior. It gets damaged with penetrating chest trauma. And this left atria compresses organs. Okay? Now, one other important thing that I want to talk about in external anatomy of the heart is, okay, 1 second. Okay, so one other thing is basically the valves anatomy. So now this is really important because when, probably you've seen the slide in your lecture, but basically the valves of your heart, if someone has some type of heart disease, want to check if the valves are working or they're broken, we wouldn't really want to go immediately inside the heart to check the valves, because this is too invasive. So there is a certain way where you can basically analyze or like test for the valves from the outside, okay? Now, why is this exactly happening? Because when the valves are closing, they make a sound. So normally, basically, or the heart sounds that you hear are usually the valves closing. If you have a stethoscope, now this is all stethoscope, okay? So the point of maximum impulse was not stethoscope. Now whatever we're discussing is with the stethoscope, right? So if you put your stethoscope on the heart, what you would be hearing is the valves closing. So you would hear like tuk tuk, tuk tuk, tuk tuk. But if a person, now this is the normal sound. If a person has a problem in the valves, what you would hear is fshtuk, 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 or tuk tuk, tuk tuk. Basically, this is describing abnormal flow of blood. This is the sound I tried to make, okay? But basically, what happens here is that there is two situations inside the body, learn it here, and it's gonna work with you in the vascular, in the heart, everywhere. So whenever you hear any type of murmur, any type of abnormal blood, any type of like abnormal sounds, it could indicate a very important thing, which is turbulence. Turbulence means that the blood is not flowing perfectly. The blood should flow in a perfect manner. I think you learned that in the foundation block, but the blood should be flowing smoothly. If there is any disruption in the flow of the blood, then this would lead to a murmur. And this is exactly what's happening here. Now, the thing that I want you to learn in order to make this easy, you shouldn't learn all these things that are created in this part or in this part or in this part. What you need to know is two things. First of all, the location, which is the aortic valve, is in the right side. So it's important because it's the only one on the right. So this is the right and this is the left. The aortic valve is the only one on the right, and it's in the second so one, two, in the second intercostal space. And then you go to the opposite side, which is the left. The pulmonary is in the second. The Erb's point is in the third. The tricuspid is in the fourth. You're basically adding one, one, one. And then you add one more, which is the fifth, the mitral. And then the mitral is the only one at the mid-clavicular line. Okay? Now I want you to remember, I have them listed down, the location. But first of all, memorize these locations, where each part is located. And then the other thing that you want to know is know if it's systolic or diastolic. Okay, so regarding systolic or diastolic, basically we have two things that we need to classify right here. We have regurgitation and we have stenosis. And then we have the mitral tricuspid valves, and then we have the aortic pulmonary valve. Okay, so mitral regurgitation. I need you guys to answer in chat. Mitral regurgitation. Is it a systolic or diastolic murmur? Mitral regurg is a systolic murmur. Why? That's correct. It's systolic. Because mitral regurg, what's happening is that basically when the heart is contracting, the blood is flowing back to the mitral, to the atria, right? So the mitral and tricuspid, when the heart contracts, blood flows back into the atria. So this is called regurg. And now this is a systolic murmur, okay? On the other hand, a mitral stenosis would be the opposite, would be a diastolic. Why? Because a stenosis is basically a stiff valve. And usually, blood flows from the right atria to the right ventricle, or the left atria to the left ventricle, with no need for contractions. It flows on its own. If there is a stenosis, means the blood can't flow on its own, and now this would lead to the murmur. Okay? So this is partly physiology. On the other hand, the aortic regurg, is it a systolic or a diastolic murmur? Aortic regurg. It's a diastolic murmur. Yes, because basically, regurg means flowing back. If the aorta is contracting during systole, then the blood is being pushed forward. So there is no type of floating back. But when the aorta is not contracted, the ventricle is not contracted, the blood can flow back. So this is referred to as regurg. Okay? So basically, now that you know the systolic murmurs and the diastolic murmurs, you don't really need to know anything else. Just know that the aortic area has the aortic stenosis and aortic murmurs. The pulmonary area has the pulmonary murmurs. The tricuspid area has the tricuspid murmurs, and the mitral area has the mitral murmurs. There is just this little bit of complication in that the aortic regurg and the pulmonary regurg are going to be heard on this part and the Erb's point, but the aortic stenosis is going to be following the rule of the aortic and then pulmonic. But for the tricuspid and mitral valve, you see regurg and you see stenosis. They're both there. Okay? So now that you know these, yeah, خلاص, inshallah. And this is the locations. The only one on the right. So, you know, whenever you're studying, if you see something that's really special, like, or different from the others, then you should keep that in mind because, you know, it's a place for exam questions. So this is the different one here. And then this one is different. So they keep these two, at least remember them perfectly, and then try to remember the other ones. All right, so this is basically external anatomy of the heart. All right, I think it was easy. So let's go to the pericardium. Now the pericardium, let's keep it simple. It's basically a sac that's covering the heart. It's made of several layers until you reach the heart. And what it's doing is that it's basically protecting the heart, providing nutrition to the heart. Now, the layers of the pericardium, you have the fibrous pericardium or the fibrinous pericardium, and then the serous pericardium. Now, the serous pericardium is the parietal and the visceral. So the way to remember them, or at least the way I used, is the P in parietal is for peripheral or outside. So it's the outer layer. And the viscera, refers to internal organs. So the visceral is covering the internal organ, which is the heart. So visceral is inside, and the parietal is peripheral or outside. And then you got the fibrous, which is the outermost. And then you have the other layers, which include the myocardium and endocardium. Now you might ask, where is the epicardium? Now, the epicardium is the visceral layer, but it's referred to as the epicardium. So it's both. I see the visceral layer and the epicardium. Okay. Now, the last part is what is a pericardial cavity and where is it located? Basically, between the two parietal, the two serous layers of the pericardium, we have a space, a small space. You can see it right here. So you see this little space between the visceral and the parietal pericardium. Now this space is important because normally it has a small amount of fluids in order to support the heart. But it's a space, it's a potential space that can grow. So if someone has some type of problem in the heart that would lead to this space filling up with fluid, what do you expect to happen? If this space, instead of being this small region, it basically took over this entire thing. So what happened is that instead of the heart being all the way out here, the heart will be all the way down here. So we're basically disabling the heart to do its normal activity because this space is filled with fluid. And now this is an emergency, and you don't really need to know that at this level, but it's mentioned in your slides, and I'm just letting you know because it's interesting to know. Now, the important points I want to discuss is the pericarditis, which is basically any itis you see is inflammation. So pericarditis is inflammation of the pericardium. And it's important for one thing, which is the phrenic nerve. Now, you might remember this from your lectures, which is something referred to as dermatomes. Now, a dermatome of the phrenic nerve is supplying the diaphragm. So that's the main function of it. That's why it's referred to as the phrenic nerve. But it has a dermatome towards the shoulder, the right shoulder or the left shoulder, mostly the left shoulder. And if any patient has any type of irritation to the phrenic nerve, they're going to have shoulder pain. And one other point is that the phrenic nerve supplies the pericardium. So if patient has heart problem, that's why any patient who has a heart attack, any patient who has pericarditis, they have shoulder pain. That's because the phrenic nerve is going to the shoulder. Okay. And now these are other features. You don't really need to know them, but basically this is chest pain, inflammation that would lead to phrenic nerve. And now this is a risky complication because with inflammation, what happens is that there's going to be fluid buildup. And with fluid buildup, you're going to have a big space of pericardial space, and it will compress the heart. So the heart can no longer beat out enough fluid, and this would lead to hypotension. And another thing you can see is something known as distant heart sound, which is basically the heart is so far behind that you can't really hear. If you put an apex beat, you can't really feel for the apex beat because the heart is all the way back. And how do you treat this? You just remove the fluid. You put in a needle and then you remove the fluid. Okay? And another thing you need to know is the surgical anatomy. Now, this part is important for you, the surgical anatomy. Now, you have two main sinuses in the pericardium that you need to be aware of. First of all is the transverse sinus, which is technically more important, I would say, because it's basically clinically really important. Now, it's a place where basically a transverse means a line, like a horizontal line. This is what transverse means, okay? So transverse sinus is basically this horizontal line that's a space behind the vessels, behind the heart vessels. So it's important because surgically you can clamp this space whenever you try and do heart surgery. And then once you close it, the heart is no longer going to be working. And that's when you can basically do your work in the heart. So this is the importance of the transverse sinus. And then there is an oblique sinus, which is, I'd say less important because it's a physiological sinus. It's located behind the left atria and it allows the atria to grow and then to contract. Okay, so it's basically just a space that allows the atria to grow and move around. Okay, but however, it's a site that fluid can accumulate because it's a space. Okay, now this is anatomically right here. So this right here is a transverse sinus. You can see it around the vessel, or like it's behind the vessels right here. So the vessels are coming down. You can clamp them from this space. And then this oblique sinus is this space behind. So right here, behind the left atria is the oblique sinus. And then in front of it and behind the vessels is the transverse sinus. Okay. The oblique sinus is outside the parietal pericardium, right? Now, صراحة, I wouldn't want to go into the complications of this and the details of this if you just remember what the function of each is, but it's basically has to do with how, when the pericardium is coming in, this balloon example that they always give where there's a balloon and then you put your hand inside and then it's rolling around the balloon around your hand. يعني صراحة it's a complicated thing if you want to think about it. But the whole point of it is that basically you have this space that you can put your finger through, because it's whenever it goes in, it rolls around and then pericardium is folding inside and outside. Just know that it creates two spaces, the transverse space and the oblique space. Okay, and the superior vena cava is inferior to it, right? What do you mean? See it right here. So the superior vena cava is posterior, and then the trunks are anterior to it. So this is the internal surface of the heart. You have the trunks or the arteries are anterior, and the vein or superior vena cava is behind it. But you can access it. It's all around there, yani. It's basically this space where you have access to all the vessels. If you remember this is more than enough. All right, so the next part is the internal features of the heart. Now here it gets a little complicated, but there is a way that basically put in a certain rule and then just check this rule off for every chamber. Okay? Because if you want to study each chamber alone, it's gonna be a little bit too much to remember for each chamber. So this is the way that I would help me. It's basically have a checklist and then cross stuff for each chamber. So basically for the atrium, you have to check off there is a rough part, a smooth part, and then the openings. And you can have special features. Ventricles, you have a rough part, a smooth part, and the valves. So this is our checklist that we're gonna go through. When we go to the atria, we're gonna check off the rough part, the smooth part, the openings. When we go to the ventricles, we're gonna check off the rough part, the smooth part, and the valves. If you remember these or keep this checklist in mind, you can just be crossing it off. So let's take this checklist and go first of all. So the right atrium. What is the rough part? Right here. We have this rough part, and now you remember the name known as the pectinate muscles. Okay. Now another thing that I would advise you to remember for embryology, whether it's embryology or for the anatomy, but yeah, it could show up in your exam, is not just remember the name of the rough part, remember the origin of it. And it's found in the next slide. But for now, let's just see it. So we have a rough part. So this is the rough part, pectinate muscle. We have a smooth part right here. And now the smooth part is called the sinus venerum. And then we have the openings. So what are the openings in the right atria? So the right atria, don't try to memorize it. Think of the function. So the right atria is receiving the venous blood, right? And so the openings should be for the venous blood. Where does the venous blood come from? Superior vena cava, and it has its opening right around here, but you can't really see it. The inferior vena cava with an opening right around here. And then the venous drainage of the heart is through something known as the coronary sinus, and it's right over here, this little space. Okay, so we finished off the rough part, we finished off the smooth part, and then we finished off the openings. So this is it for the atria. Now, in regards to the right atria, it's a little bit, it likes to have something special for it. And this is known as the fossa ovalis. This is basically an opening inside in the interatrial wall. Between the right atria and the left atria, there is this basically hole known as the fossa ovalis. And you probably learned it in embryology, which is the foramen ovale. I'll discuss it later in a second, but just remember that the right atria is a little bit special and it has its special parts other than the rough, smooth, and the opening. So it has a fossa ovalis. The right atria would have the SA node, and right around here, you will have the AV node. Okay, so the right atria, smooth part, rough part, openings, and the special features are the fossa ovalis, SA node, AV node. Okay, great. Now, we said we have a rough part, which is known as the auricle. Now, the auricle, if you want to look at external heart anatomy right here. So this is the auricle. It's basically this little, or it's known as an auricle or appendage of the heart. It's this thing that's basically, you can see it outside in the atria. The other parts of the atria are inside, you can't really see them. You can see this thing. So this is the rough part, okay? And it's rough because of the muscles. And it's referred to as the auricle, and the embryological origin is the primitive atrium. The smooth part is basically the sinus venerum. The origin is the sinus venosus, right horn of the sinus venosus. And then these are the openings. And then the other special features are the AV node, the SA node, and the fossa ovalis. Okay? Now, a way to remember that the SA node is near the superior vena cava and the AV node is near the coronary sinus is basically, the way I remember it is that the S is for the S. So SA node is the S is superior vena cava. And then the V here, or the AV node, is for the venous drainage. So venous So the venous drainage of the heart, the coronary sinus. So the V for venous and the S for the superior vena cava. Okay. Now I said that it's the crista terminalis. Now this is basically the crista terminalis. Now this is basically the heart appendage, right? It's covering over the heart right here. What they did is that they opened it out. Now if you bring it back in here, right here is the SA node, you're gonna have it, or right here. If you bring it back towards this part of the crista terminalis or the upper part, you're gonna have the SA node. Okay. Now let's take the right ventricle and apply our rule. There is a rough part known as the trabecular carne. There is a smooth part known as the conus arteriosus or the infundibulum. And then there is the valves. For the ventricles, we have the valves. Now, the tricuspid valve is a tricuspid. So basically 3 heads. 1, 2, 3, tri. So it will have 3 leaflets right here. You see, 1, 2, 3. Now, another important part in valve anatomy, basically, you have a cusp, which is right here, the opening, a cusp of the valve. And then it's attached to these fibers, and then these fibers are called the chorda tendineae, and these fibers are attached to a muscle in the ventricle, known as the papillary muscles. So there is a rough part, trabecular carne, a smooth part, conus arteriosus, and then the valves. Valves have a cusp with fibers with muscle. Muscle, fibers, cusp. Okay? It's basically threes. Everything is threes. 3 special features in the atria. 3 features in the valves. 3 things that you want to look at. Okay? Now, I don't know if you guys know this, but there is a way to remember that the tricuspid valve is on the right and the mitral bicuspid valve is on the left, which is the RI, so the tri or the right. Okay? So basically this helps me a lot. So if you guys struggle with how to remember which is which, so a tricuspid is on the right, and then the mitral bicuspid is on the left, since this one is on the right. All right, so we have a trabecular carne with the origin, we have the conus arteriosus with the origin, and then a special feature right here is a moderator band. It's found in the right ventricle, and it's helping with conduction. Basically allows the current to go in. Okay? Yeah, so don't really worry about it. Just know that there is a moderator band attached in the right ventricle, and it's basically allowing electrical signal to pass through. And we said there is 3 cusps with 3 fibers and 3 muscles. Okay? Left atrium, applying the same rule. We have a rough part. Now the rough part right here has been removed off. So the rough part we said is the appendage or the auricle. It's basically this little chunk right here is left of it. But in order to see the inside, we have removed the rest of the left atria. We have a smooth part, which is basically this right here. And then we have the openings. So we have the openings for the pulmonary veins. Why? Because the left atria is receiving the pulmonary veins. And then right here, you can see the foramen ovale. Basically, the same thing on the opposite side. We said that the fossa ovalis, foramen ovale, is between the left and right atria, so you can see it technically on both. But once it's closed and after development, you're mostly seeing it on the right side. Okay, so we said the rough part, the smooth part, and the openings. The rough part, the auricle, primitive atria. The smooth part, which is the primitive pulmonary veins, and then the openings is the pulmonary vein openings. Okay, and if you notice that the rough part in the both atria is the same. Okay, so this helps you. Primitive atria is the same. Now this is the left ventricle. Again, we have the rough part right here, this trabeculae muscles. We have a smooth part, which is around here, but you can't really see it. And then we have the valves, which is now this is the bicuspid valve or the mitral valve. It has 2 cusps right here, 2 fibers, and 2 muscles. Okay, this is the mitral bicuspid valve. There's a primitive, there is a bulbus cordus, which is the smooth part right around here under the aorta, or the aortic valve, I mean, and then the valve features. Right. So I think if you guys just, remember this rule of the rule of 3, I guess you can say, or something like that. But just remember these 3 things, the origin, and then what it is, and then cross them off for each chamber, and khalas, you can remember them like that. Now, other important features of the heart, which are, you can easily get the hang of them, على طول, which is basically, first of all, there's an interatrial septum, which is basically a septum between both atria. And now it has a foramen ovale or a fossa ovalis, which can have an atrial septal defect if this foramen ovale, this space right here, doesn't close up. I have another slide for it in a second, and I'll show you. So I don't want to explain it now. because I have pictures there and that would make it easier. But just remember there is an atria, there is a foramen ovale in the interatrial septum. We have the ventricles. It's two parts of the interventricular septum. There is a muscular part and there is a membranous part. The membranous part is weak, and if a patient has ventricular septal defect, it's going to be occurring in the membranous part. Okay. We have the SA node. We set the S for the S, so it's around here, superior vena cava. We have the AV node, it's a V for the veins of the heart, so it's around. But the AV node is basically in the interatrial septum. It's more of right here, so near the opening. So basically the opening's around here. The SA node is around here. Now the SA node is around here, and the AV node is around here. There is another picture later, but basically just remember it's near the coronary sinus opening at the interatrial septum. Okay, oh, there it is. Okay, so this is the opening of the coronary sinus right around here. And 1 second. Okay, so right here is the opening of the coronary sinus, and you can see there is an AV node. Right here is the opening of the superior vena cava, and you can see there is an SA node. And then this is the conduction pathway. So for the valves, you have the cusps, you have the papillary muscles, and then you have the fibers, which are called the cords, the cord, the tendini, or the fibers, or the cords hanging on each valve. Now, I put this slide because there is a difference between the tricuspid mitral valve and the aortic pulmonary valves. Is that you notice that if you say, for example, here, the aortic valve has no fibers attaching to it, no muscles attaching to it, or no nothing. It's just there. It's a cusp. But for the tricuspid, we have these. Now, basically, this just affects the way it works. So if the left ventricle, for example, blood flowing around here, these fibers are holding this valve in place. Because it's not as well established as these valves. So it needs support. And then the blood can flow in, and then these muscles can pull them down and basically allow the blood to pull, and they're basically allowing it to close, and they allow it to work. However, in the aortic valve, which you can also see it in the pulmonary valve, it's the cusp. They are sitting there and they're closing the space. When blood pushes through, it just opens the space and goes through. And then they think that whenever you push them out, they move away, and then you close them on their own. So there is no really mechanism for them. There's no fibers, there's no muscles. So, and now this is basically what you need to know. Now, another thing is that basically for the aorta, there is this small opening in the cusps of the aorta. Now, these openings are important because basically the aorta, or the heart itself, it needs blood supply. And now, how would the heart get blood supply if the aorta is coming out from the chest and going away to the body? So once the heart pumps the blood away, it can no longer come back to the heart. So subhanAllah, we have this mechanism where when the heart is pumping off the blood out, some of the blood stays down here, right? Because it wasn't able to move through. Now the blood that stays down has these little openings, so the blood is filling up these cups. And now there is these openings which will basically take the blood and supply it to the heart. And this is how the heart gets its blood supply. Okay? So the heart gets its blood supply through these. Now, here I highlighted this part and the papillary muscles. Now, I'm not really sure if you'd get questions about it, but it's important to keep in mind. So the mitral valve has two papillary muscles, the anterior lateral papillary muscle and the posterior medial papillary muscle. The posterior medial muscle has a single blood supply, right? So it's at a high risk of injury. So if a patient has an injury to the posterior artery, they will damage the posterior medial papillary muscle. So if you get a question about which of the following is more likely to get injured, then it would be posterior medial papillary muscle. Now here is the patent foramen ovale. Okay, so embryologically, now let's talk about embryology of it. Basically that a child is in the embryology, right? He's inside his mother's womb. He has no access to the outside space. He can no longer breathe. There is no oxygen in the blood. And so how would the child get his oxygenation? ASD, okay, I'm sorry. ASD is the atrial septal defect. The atrial septal defect. And the VSD is ventricle septal defect. Septum defect. All right, so let's go back to this part. Now, a child has no oxygen, and the way the child gets his oxygen is from the mother. And then the mother would get the blood in the child to the veins of the child, and then the veins will bring it to the heart. And now the right atria of the heart is having the oxygenated blood, right? But the right atria is not connected to the body. So the body has two mechanisms to bypass the lung, which is useless in the embryology, in order to get the blood, which is oxygenated, into the left atria and the left ventricle so that it can go to the aorta and get supplied. One of these ways is through the patent foramen ovale, which is basically allowing it to go immediately to the left atria and then down the left ventricle and out to the aorta. Or some of the blood would flow down to the right ventricle, and then from the right ventricle to the pulmonary valves. But subhanallah, there's another connection between the pulmonary vessels and the aorta, so that once it reached the pulmonary vessels, instead of going to the lungs, it would go back to the aorta. And this is the ductus arteriosus. So why? Because the lungs are useless in embryology. Okay? So this is why we have a patent foramen ovale. Now, usually though, after birth, the lungs are now functioning. So this patent foramen ovale is gonna basically close off. However, if it doesn't close off, there's gonna be a disconnection or disruption between these two atria, and then the blood is gonna start having a problem because it goes here and then goes down, and then the oxygenated blood and the deoxygenated blood are gonna start mixing. So we don't want that. خلاص, the body is there, the lungs are working, everything should function as it should be. All right, any questions for the internal features of the heart? Okay, let's go to the next part. Now, the arterial system. There is one main concept that I want you to learn, and then the other things are basically you memorizing what each part is supplied. So the main concept here is basically dominance. Now, dominance is referring to whether a person is a right coronary artery dominant or a left coronary artery dominant. And this depends on where does the posterior descending artery come from. If it's a right dominant, it's gonna be the right coronary artery gives the PDA, and if it's left dominant, the left circumflex artery gives the PDA. LCX is the left circumflex artery, and the RCA is the right coronary artery. Okay. Now, the way I remember it is that most of them are basically the right coronary artery is the PDA, is that the left artery comes off the left coronary and gives off two branches, the left circumflex and the left anterior descending. So the left artery is already doing its job. So it doesn't really need more burden on it of releasing another PDA. So that's why the right coronary artery, if the left coronary is going to do everything, the right will have nothing to do. So that's why the right, most of the time, is taking that job and doing its part. So that's the way how I remember that 85% are basically right coronary artery dominant. Okay? So just basically remember that the left has a lot of work, so the right is going to want this thing for itself. Okay? Now, why is it important? Because now the dominant artery gives off the PDA. Now, this is most important part. Why? Because the PDA determines the dominance. However, also in these people, the dominant artery is responsible for supplying the AV node. So the SA node and the AV node, they don't really have a constant blood supply. So for example, the left ventricle is supplied by the left arteries. But the SA node and the AV node, I can't just say that they're always supplied by the left arteries, or they can't say they're always supplied by the right artery, because it varies. And for the most part, they're going to be supplied by the right coronary artery. So just remember that, again, the same rule applies, that the left artery has a lot of work, left circumflex and left anterior descending artery. So the right artery wants more work, which is basically giving off the posterior descending artery, the AV node supply, the SA node supply. Okay? Now, with that being said, the important vessels are right here. So we said that this is the aorta, the aortic valves. The blood sits around here and then goes into these openings. You have two openings. First of all, this is the right side, and then this is the left side. The left artery has the left anterior descending and the left anterior descending and the left circumflex artery. And now, two important things you need to know, or the main important thing, is that the left coronary gives off the left anterior descending and the left circumflex. Now, sometimes they might ask you about diagonal branches or marginal branches. Just remember that the left anterior descending gives off the diagonal branches, while the left circumflex gives off the marginal branches. And on the right side, we have the right coronary artery supplying the SA node, supplying the AV node, and then giving off the posterior descending artery. Okay? And there's another branch, which is the right marginal artery, which is given off by the right coronary artery. But main ones are the PDA, the left circumflex and the LAD, and then the SAAV node branches. Now this is an imaging for the heart vessels. Now right here, basically you can see This is the right coronary artery coming down. Now, how would you know if this is right or this is left? Okay, 1 second. Let me just erase everything. Okay, awesome. The way you remember that, oh, you don't get confused, is this right, is this left? You can see right here, the left coronary immediately splits out into two. The right coronary walks, it wants to work. So the artery that splits immediately is the left. So this one splits immediately. So this is the left. This one goes on its way. So this is the right. And if you see a right, and if they ask you what this branch is, immediately, what's the most important branch of the right? The PDA. If you see the left, you have two valves, or you have two main vessels, the left anterior descending and the left circumflex. How do you tell them apart? The one that goes to the apex is the left anterior descending, and then the other one is the left circumflex. Okay? As simple as this. Just remember which one splits first, and then the apex or the left circumflex. All right. So this is the basic pathway. So from the left ventricles to the aorta that sits in the aortic cusp and leaves, this basically occurs during diastole. Why? Because when you're pushing the blood out, it's going up all the way. But when you relax, the blood falls back and then it goes into the openings. And then they exit at the atrioventricular groove, which is basically, this is the ventricle, this is the atria. And then right here, the atrioventricular groove is basically where the vessels are exiting. You have the left coronary, which immediately splits into left circumflex and the LAD. You have the right coronary, which wants to do her job, or so it has the PDA. And then it works. It has a longer pathway. Okay. All right. Now, here another part of the supply. Basically, the left coronary artery gives off nothing. The left circumflex is supplying the left ventricle, or the lateral part of the left ventricle. The left anterior descending is supplying the anterior 2/3 of the interventricular septum and the apex of the left ventricle. You don't really need to know this part. The right coronary is supplying the right atria and the right ventricle. The PDA is supplying the posterior 1/3, and also this one is basically, remember how we said it's a single blood supply? The anterior lateral has two supply from the left circumflex and the LAD, while this one has only one supply, so it's high risk of getting damaged and injured. All right, and it depends on the dominant artery. Okay. Now here is what we discussed. So see this is the posterior medial muscle, and it's weak. So what happens here is that we have rupture. So the blood is gonna flow back since it's no longer able to support this valve, and you get mitral regurgitation. Now this is really important if they want to say that someone has an occlusion in the right coronary artery, because the right coronary artery. So خلاص, for now, I'm moving on. Unless they mention that a person is left coronary dominant, or they're asking you what is the dominance of this patient, and they give you the PDA is coming from here or from here, assume that every person is a right coronary artery dominant. The right coronary is giving the PDA. The right coronary supplies the SA node and the AV node. Okay? خلاص, keep it a rule. Assume, because statistically speaking, the right coronary artery is more commonly to do that. And basically, so if you have an occlusion of the right coronary artery, you have a disruption of the PDA, which is the PDA supplying the inferior surface of the heart and the posterior surface. You have a disruption of the posterior medial papillary muscle. And then there is one other structure supplied by the PDA that's going to get disrupted. We mentioned it earlier. What is it, guys? This is a question for you. So the PDA supplies the heart, the lateral, the inferior and the posterior surface, supplies the muscle, and then once other structures are supplied by the PDA or the right coronary artery. It's right here. The AV node and the SA node. Okay. So right coronary supplies the SA and AV node, the muscles, and the papillary muscle. All right. Now, on the other hand, you have the venous system. So the venous system, the important thing that you need to know is that there is a great cardiac vein, there is a middle cardiac vein, and then there is the small cardiac vein. So they have a nice name: great, middle, and the small cardiac vein. And then there is other smaller veins, which are the anterior cardiac veins, and then other veins. Now, what you want to know, two important things when it comes to veins. First of all, what is the main vein of the body, which is basically the heart, the coronary sinus. So the great vein, the middle vein, and the small vein, all of them open up into the coronary sinus. So 1, 2, 3, and all the other veins of the heart open to the coronary sinus. And then the coronary sinus goes into the right atria. And then the other important thing that you need to know is where do they run and what runs with them. So let's say the great cardiac vein. The great cardiac vein is running in the anterior interventricular septum, or not the anterior, I mean, yes, anterior interventricular septal area. Here's the right, this is the left ventricle and the right ventricle. And what was running here? The LAD. The posterior interventricular septum has the middle cardiac vein with the PDA. And then this right here is the right side. So the right coronary artery has the small cardiac vein in the atrioventricular septum. Okay. So here it is. Great cardiac vein is with the LAD. Middle cardiac vein is with the PDA. Small cardiac vein is with the RCA. Okay. Now, other veins mentioned in your slides include the Thebesian veins, which is great, middle, small, and the smallest. They're basically small veins scattered around, emptying into the heart chambers. Just remember this line a bit. Small veins around the heart draining directly into the heart. They don't go to the coronary sinus. The anterior cardiac vein, which is really important because also it drains directly into the right atria. It does not go to the coronary sinus. You can see it right here. Okay, so it's opening directly into the right atria. It doesn't go to the coronary sinus. And then you also have the posterior cardiac vein, which is another vein. Now, the posterior cardiac vein doesn't really have anything special to it. It's just another vein that goes to the coronary sinus, supplies just like the other veins. It's just a vein that drains the left ventricle. Okay, so the great, middle, and small cardiac veins, remember what they run with and where. So, for example, if you get an OSCE question about this area and they point at this region and they said, what two structures run in here? And they put a pin right here. Then you say the great cardiac veins and the left anterior descending artery. All right, now here I put another picture where you can see them running together. So the great cardiac vein with the anterior interventricular artery, or the LAD, I mean. Here you have the great cardiac. This is another view that the great cardiac vein also runs with the left circumflex. Okay, so basically the left circumflex and the great cardiac veins run together. Because if you see the great, let me show you it. I forgot to explain it here. So the great cardiac vein comes around here and then rolls to the back. We have the coronary artery, the left one comes out here. It gives off the left circumflex to the back and LAD. So you see the great cardiac veins covers both the left circumflex and LAD. Okay. And then you have the small cardiac vein with the right coronary artery, or right here. This is the right coronary artery. You have a small cardiac vein supplied right here. You have the middle cardiac vein, which is the posterior part. It's running with the posterior interventricular septum. And then you have the coronary sinus, which is the opening right around here. Okay. Now here I cleared up the picture so you can see them again. So this is the coronary sinus. This is the posterior. This is the anterior. This is the left circumflex. And this is the right coronary artery. Now this is another view where it's all cleared out. This is the middle cardiac vein and the posterior. This is the coronary sinus. If you see a big vein, then this is the coronary sinus. This here is the left atria. This is the right atria. And this is the left ventricle. This is the right ventricle. Okay. Now the relationships. Okay. And this is another picture showing you the heart supplies. Yani, I mentioned them in different ways so that you guys can find the way which is you're more comfortable with learning. So whether you want to learn what the artery is and what it supplies, or what the chamber is and what it receives supply from. And again, the SA node and the AV node are by the right coronary artery mostly. And the PDA is mostly by also the right coronary artery. Now, another way that I mentioned them, if you want to learn the chambers, what supplies the chambers of the heart. And now, why is this all important? This is just, a clinical information that you guys can see, and basically something interesting to know. Why exactly do we need to have, well, why exactly do we need to know what each artery supplies in the heart? It's because if a patient has a heart attack, okay, a patient comes in, he has a heart attack. What's a heart attack? A myocardial infarction or heart attack. It's when one of the arteries supplying the heart gets constricted or gets some type of problem. So basically, the area of the heart supplied by this artery is no longer receiving blood flow. Okay? So an area of the heart supplied by an artery is no longer receiving blood flow. If it's not receiving blood flow, it will die. So, for example, right here, we have an artery. What is this artery? You guys should be able to name this artery. So this artery is the the LAD, because it's running in the anterior interventricular area. So this is the LAD. So we have a constriction here, and you can see the area after it is dead. Now, why you need to know what each surface supplies and what its surface is receiving from is when a patient comes in, he says, "Oh, my chest is hurting." But he's not gonna tell you, "Oh, my chest is hurting in the LAD distribution or in the left circumflex distribution or in the area of supplied by the right coronary artery." He's just gonna say, "My chest is hurting." That's if he was even able to speak. So you're not gonna go inside and start looking into their scopes or whatever into every heart vessel or every heart supplied by the every vessel supplying the heart. You're not gonna be going in looking for them and searching for them. So what they would do is basically an ECG of the heart, and each vessel supplies a surface which shows a change on the ECG. So the ECG is basically a 2 minute thing. A patient comes in, 2 minutes, you attach the cords, and then you take an ECG. The ECG would tell you, for example, if we had a problem in here, then immediately you would know it's caused by the left circumflex artery. So you don't really need to do the, and then instead of going in and searching for which artery has a problem, you go inside and treat the problem of the left circumflex artery. But you don't really need to know that. I'm just giving you, like, these facts, just remember them as a fun way of understanding them right now, because when they come to you later on, خلاص, you don't really need to worry about understanding them again. But just remember them as fun facts, okay? All right. So this is basically why we need to know what each heart vessel and which surface is supplied by the heart vessels. And then again, we said the posterior here is just applying the ventricle, the papillary muscle, and the SA and AV node. All right, so this should be 99% of our lecture. Do you guys have any questions regarding anything discussed? All right. But now the other thing, I just added this part because, yeah, it's the basic anatomy. First thing you need to learn in the heart, whenever you're doing like CVP, it's basically the blood flow, the way blood flows. So the blood flows from the superior vena cava, inferior vena cava to the openings, and then the coronary sinus opening to the right atria, to the right ventricle, to the pulmonary arteries, and then comes back to the left atria through the pulmonary veins, the left ventricle, and then the aortic valve. It's important to know because they might ask you, well, what comes after this? What comes after that? And I just put it because it's part of the heart anatomy. I know it's easy. The other thing is the conduction pathway. So you have an SA node, which gives off supply to the atria. This is physiology. The SA node gives off supply to all the atria, right and left. And then it goes over to the AV node. So the AV node, what's important is that there is a delay in the AV node. And why exactly have this delay is because, so once the atria are contracting, we don't want the ventricles to contract at the same time. So we have the atria contract, the ventricles are relaxed because the circuit is stuck in the AV node. And then like a couple milliseconds later, it can pass through the bundle of his to the right and the left bundle branches and supplying the heart. Another physiology thing that you might get asked is which of the following of these five has the fastest conduction and which has the slowest? Do you guys know which has the slowest? Slowest we said is the AV node. Which one has the fastest? The Purkinje fibers, yes. So you might get asked that question. And that's it. Okay, so practice questions. A 27-year-old cardiac patient with an irregular heartbeat visits a doctor office for examination. Where should the physician place the stethoscope to listen to the sound of the mitral valve? Yes, sir. Correct. The answer is D. Left intercostal space at the mid-clavicular line. It's one of the two high-yield ones that I said. If you want to remember, at least remember them. Which one is heard on the medial end of the right intercostal space? Second right. The aortic, exactly. And then the other ones, if you know them, yeah, that's better to know. Okay, now here, a patient who has a posterior interventricular artery. What vein is running with the posterior interventricular artery? The middle cardiac vein, B, correct. Okay, so we have a patient here who has a posterior anterior chest radiograph. Which of the following composes the largest portion of the sternocostal surface? The sternocostal surface is the anterior surface of the heart, and it's D, the right ventricle. That's correct. So again, we said if you want to remember too, the right ventricle is the most anterior, and then the opposite is left, and the left atria. So opposite is left atria is gonna be the most posterior. This one gets injured in trauma. This one compresses the esophagus. Okay, so a patient with an atrial septal defect, hypertrophy pulmonary trunk. Okay, so a patient has a hypertrophy of the question is asking hypertrophied atria or hypertrophied right atria. Which of the following opens into the hypertrophied right atria? The We got only one answer so far. I'll give you guys a second. Which of the following opens directly into the right atria? D. Okay, so you guys are right. So the correct answer is D. Now, here's another question from me. List three other structures that open directly into the right atrium. Three other structures that open directly into the right atrium are your IVC, SVC, and the coronary sinus. Exactly. So, and basically based on that, the middle cardiac vein, the small cardiac vein, the oblique cardiac vein, all these go to the coronary sinus. Everything goes to the coronary sinus except the anterior and these other veins that we talked about, the thalesian or the smallest or whatever. The pulmonary veins is gonna go over to even though it says right, but all the pulmonary veins, they go to the left atrium. All right, so that's it. So do you guys have any questions regarding any part of the slides? Here, card. Okay. Any questions? All good. All right, thank you everyone.